steps and things kind of overwhelm you. The main thing is being able to identify what's important so that you can go back and learn it at your own speed. All right, and then by you doing that, that will help um, move you closer to the process or the goal of being ready and prepared for your exam. So that's the big thing to remember in this process. So just kind of not let it overwhelm you. Okay. Um, and I know it's I mean, whenever you look at the book and how much we've done in 2 days, it's pretty significant. And so we just want to make sure that uh, you're reminded that just the attitude of going through the process and your anxiety level is one of the most important things that you can learn to manage, because on the test, if your anxiety level goes up, then of course that creates um, more difficulty in your thought process, and therefore makes it more difficult for you to pass the test. So looks like we still got a few more minutes here before it's time to start. I've already gotten, I think, one text from somebody that they may be a little bit late. Okay. All right. Well, we're right at 11 o'clock. We still got a few more people coming in. Looks like we're at right about 41. So what I'm going to do here again as we get started again is just reminding people that hopefully those of you who are having issues with your latent image pins, hopefully those, it's my understanding those should be delivered today. So I'm not sure what time your UPS or FedEx delivery person gets to your location, but just kind of keep an eye out for those things. If you don't have a latent image pin, whenever we get ready to start doing the clinical simulations, just kind of send a chat message or something to Tom and let him know, and he can kind of give you some suggestions of maybe what may work until your pin can arrive. Let's see, what else am I supposed to say here? Oh yeah, okay. So what we've done yesterday is kind of start in respiratory or start in mechanical ventilation, section echo or E. And so we're going to continue that today. And before we get started, we're going to kind of do a brief review of what we did yesterday. Once again, for some of you who are just now joining us, I want to remind you that, again, that you're going to get more practice doing blood gas interpretation. You're going to get more practice doing ventilator settings today and tomorrow. So as we go through that, by the time you get finished with this process, it should be a pretty easy process to remember as you go back through and prepare and study for this for the exam. So just don't let all that stuff we went over yesterday overwhelm you, is kind of the message I gave early on as I came on this morning. All right. So with that, I am going to take me off the screen.
Okay, John?
Yes.
If you could just briefly go back to one page and point out what they should highlight. I had somebody ask.
All right. Which page is that?
Sorry to interrupt, but I know it'll drive her crazy the whole day.
Okay.
Okay, we're going to page D as in dog 40.
Right.
Starting with section with letter H, I guess.
Starting with letter H, so basically towards the end of the page there.
Letter H as in hill. So just, I guess, H, I, and J on page D40.
Okay, all right, so the request here for D40, if you're on page D40, starting with letter H, you want to highlight letter H. Under letter H, number 1, 2, and 3. Letter I, under letter I, numbers 1, 2, 3, 4, and 5. And then under letters J, number 1 and number 4. And that would be all of them for page 40. So is that it, Tom? Or
That's it at this
Okay.
point. Thanks,
right.
John.
okay, thank you. All right. So what we're going to do right now, as people continue to come in and join us, we are going to do just kind of a brief review. Get my slide to advance here. So yesterday we left off in mechanical ventilation. We were talking about the 3 phases of mechanical ventilation. Phase 1 is what we're working on right now, is how do you know when to put somebody on a ventilator? And so in order to know when you need to put somebody on a ventilator, you've got to first off know when it's indicated. So you've got to be able to interpret your blood gases to know that they got poor ventilation. You've also got to be able to interpret your mechanics, your spontaneous mechanics, like your MIP, your vital capacity, spontaneous vital capacity, and spontaneous tidal volume, the MEP. All of those things you've got to be able to assess to determine, yes, this person needs mechanical ventilation. And then what we did is we moved to, okay, once you've decided that they need mechanical ventilation, how do you know what settings to put them on? All right. And so the settings that you put them on, we gave you a box, and basically these are the guidelines that we recommend. And here again, I know some of you are saying, this wasn't what I was taught in school, the 5 to 10, but I'm just suggesting that you use that on this test. And if it confuses you and messes you up, use whatever you want to. I mean, as far as the appropriate range I think what they're suggesting now is, of course, 5 to 8. Okay. But for me, the math, it's easier to do the math this way. It helps me to move through the TMC quicker, so I don't have to stop and use a calculator and all that kind of stuff. And so that's why I typically like this. And again, it's easy for me to check my math. So that's why I typically use that. Here again, 35, less than 35 on your, if you're going to be ventilating with pressure, and then your rate should be somewhere between 10 and 20, FiO2 40 to 60% if they're on room air. However, if they're already on oxygen, we'll put them on the same concentration. And then if there's no prior information, we'll put them on 2 to 6 of PEEP. If they're on CPAP, we're going to put them on the same level. So again, this box is very important for you to know how to determine what your initial settings should be. Now, the process of going through and doing the information is, you first off have to be able to calculate your ideal weight. And again, we've shown you how to do that. Just take the inches over 5 feet and double it, and then add that to 50 kilograms. We're giving you that example. I think Tom even mentioned yesterday, somebody had said that, well, they've got a different way that they do. I mean, again, if you're comfortable with doing ideal body weight a different way, and that's what you feel most comfortable with, I mean, by all means, continue to use it. You should come up pretty close to the same answers we're coming up with, okay? And it shouldn't affect what the actual answer that you select on the test would be. But if you, for me, it's just, this is an easy formula to remember. And again, you do the same formula for both male and female. And so that's kind of why I like this particular method, okay? So as we go through that process, and once we've got the ideal body weight that's been calculated, then what we're going to do is determine our tidal volume. So we're going to take that ideal body weight and multiply it times 10 for our range. That's to get our upper limit of our tidal volume. So for our example here of a 70 kilogram person, we'd take 70 kilograms, multiply it times 10, and that would give us 700 cc. So that's my upper range for my tidal volume. Then what I'm going to do is I'm going to cut that upper limit in half. All right. And so whenever I cut that 700 cc's and divide it by 2, cut it in half, that's going to give me 350. That will give me my lower limit of my tidal volume range. And so my tidal volume range, when I write it on my piece of paper, should look like this, 350 to 700 cc's. That's the range I'm looking for in the answers that the test offers me. All right. Now, technically, again, this 700, that's typically too much. All right. But this middle range here, if you shoot towards the middle, which is 500 to 600, that's going to be in the middle between the 350 and the 700. If you look for a tidal volume in the answers somewhere here in the middle, you're going to be pretty much right on target. Okay, and like I said, this typically works very well on the test. There may be an outside chance that one question was maybe off or something, but I'm telling you, if you use this method, you will probably get 95 to 98% of the questions correct on the test by using this method. Right? So what we're going to do now is on page E13, we're going to talk about infant ventilator settings. And again, this is another box. Remember, there's not a lot of stuff on the test about infants, but you have to modify this box in phase 1 for setting up an infant on a ventilator because the adult box is not going to work. All right. So here we are in phase 1. We've got another box that we need to remember. The good news is this box doesn't really change that much, all right, from the adult box. And we'll show you how that works here in just a minute, okay? And then it'll be a good practice for us to go back through the steps of how we would calculate or use the box to figure out what the tidal volume should be for an infant in our example, all right? So the box here on page E13, top of the page, the range there is 4 to 6 mils per kilogram. Now for me, I still just go ahead and do my standard calculation of 5 to 10 because what is the number in between 4 and 5? I mean 4 and 6. Yeah, it's the number 5. And so if I just use the lower end of the tidal volume calculation for the adult, it's going to put me right in the mid range for the infant tidal volume. Okay, but I'll show you that here in just a minute. So you can either just learn a new number or stick with the number that I've already given you, and just remember if you're dealing with a baby, you need to use the lower range, lower limit of the tidal volume. If you're going to be ventilating the baby with pressure, we use a lower pressure, 30 now. Okay, that's the maximum we can do is 30. All right. So we don't do 35. So we drop our pressure a little bit. And notice that our respiratory rate increases because babies have faster respiratory rates. We basically just increase it by the range by 10. So from instead of 10 to 20, now we go from 20, increase it another 10 to 30. All right. So this first part up here is a little bit different than what we're used to seeing for an adult, but not that much different. Okay. As far as the FiO2, we pick the FiO2 the same way we do for adults. It's going to, if they're on room air, we're going to start them off on 40 to 60. If they're already on oxygen, we'll put them on whatever level of oxygen they're on at that point in time. As far as PEEP, no prior information. Again, it's going to be 2 to 4 instead of 2 to 6. Again, this is a baby, so we're going to drop the upper limit down just a little bit. However, if they're currently on CPAP, we'll put them on the same level. All right. So let's look at an example here of how we would calculate ventilator settings for a baby. And it's going to be very similar to what we would do for an adult. So this is a good review for what we did yesterday when we ended the day. So following 28 weeks gestation, a baby girl is born with a birth weight of 2,000 grams and an APGAR score of 1 and 2. Okay, so obviously that's pretty low, and that means probably there's going to need to be some assistance here as far as ventilation and so forth. Prolonged apnea, because of prolonged apnea, the neonatologist has intubated the infant, and manual ventilation is being provided at an FiO2 of 65% and pressures of 22/4. All right. Now they've already are ventilating at this level. And so this is typically, we're going to start them off on the same level that they're bagging them at, okay? So at 65 and 22/4 is probably acceptable. But the one piece we don't have, when it, of course, the question asks, which of the following ventilator settings would be most appropriate? We don't have a tidal volume, okay? So again, we go to the box to guide us. And the thing I think I forgot to do this yesterday. I'm almost positive I did. Let me go back here for just a second. One of the things that, again, we said at the very beginning of our webinar was that our 4 life functions are ventilation, oxygenation, and circulation and perfusion. So notice that the first things that we calculate for ventilator settings are related to ventilation, the tidal volume, the peak pressure, and the respiratory rate. So we're always putting ventilation first in everything we do on this test, all right? So that's why we're calculating these things first. Tidal volume, peak inspiratory pressure, and respiratory rate. We're assessing and deciding what we should use for the patient in order to take care of the ventilation life function, okay? And we said the next life function was oxygenation. Well, notice that the next two, all right, the next two here deal with oxygenation, FiO2 and PEEP. So those, by choosing and using our box and using it in the order that we've given it to you, you've got the steps of how you should approach choosing ventilator settings as far as what's most important, moving on down to the least important. Okay? Now, with that being said, as we go over here to our example, we need to go through and calculate our ventilator settings on page 13. So you kind of work through this with me. So the baby, the ideal weight, they only gave us 2,000 grams. And so basically we have to go by the weight that they give us, and then we have to convert it to kilograms. So that's going to be 2 kilograms, excuse me. All right, so they haven't given us a height. So this is all we can go by, all right? So we're going to take that, take the 2 kilograms and multiply it times 6. Again, if you look at the box, that's the upper limit, and that's going to equal a tidal volume of 12 mils. That's going to be our upper range for the baby for tidal volume, all right? Then we're going to take the 2 kilograms and multiply it times 4. Again, if you look at the box, the lower end of the range is 4 mils per kilogram. So 2 times 4 gives us 8 mils of tidal volume for the lower range of this baby's tidal volume range. Or if we're going to ventilate the baby, we need to ventilate them with the same pressure that they're on. They're at 22, and so that's why this is 22 instead of 30. Okay? All right. Now, let me show you John's method. You can do it just straightforward like we've shown you here, or what I do, I just take the 2 kilograms, multiply it times 10, like we do for an adult, and that gives me 20 mils. And then I take that 20 mils and I cut it in half. Half of 20 is 10, and that puts me right in the middle of the upper and lower range. Because we said the upper range is 12 and the lower range is 8. So 10 is between 8 and 12. So that puts me right in the middle of the range, okay, just by using the lower adult range. All right? So I could go a little bit higher than 10 mils, or I could go a little bit less than 10 mils. And again, by doing that, I'm still within this 8 to 12. All right? So that's just another way of doing it. All right? You pick which way you think works better for you and makes most sense to you there. All right? Again, the rate is going to be 20 to 30. That's from our box. The FiO2 in our box said if they're already on oxygen, we're going to give them the same amount of oxygen. So that's going to be 65%. And then same thing with the PEEP. If they're already on PEEP or CPAP, we're going to put them on the same CPAP level. All right. So they're on 22/4 is what they were on by bagging. So that's where this 4 came from. Otherwise, we would use 2 to 4 for the range for the baby. All right. So those are my settings. And once again, For every mechanical ventilation patient that they ask me to set settings, I'm not looking at blood gases. I'm simply going to my table and writing out what the settings, initial settings should be in phase one. Okay, if this is initial ventilator setup. All right. So let's go to our answers. So I'm looking at my answers here, but before I look at my answers, I want to make sure I got a piece of paper that's got these settings down there. So here are my tidal volume, 8 to 12, or PIP around 22, okay, at 22, frequency 20 to 30, FiO2 65%, and my PEEP of 4, all right? So I'm using this piece of paper here to help me find the right answer in all this up here, all right? And so I'm going to start right here at this tidal volume. Could I use this tidal volume? No, it's too high. It's over 12, right? So I can't use letter A. Drop down to letter B. Could I use this tidal volume? Yes, I could use that tidal volume. Could I use 22 for a rate? Yes, I could use 22 for a rate because it's between 20 and 30. And could I use an FiO2 65%? Well, yeah, because they're already on 65. That's what I want. And could I use 4 of PEEP? Absolutely, that's on my list there. Okay, so this is the correct answer. But let me just go down through and show you again on the last two answers how you would rule these out. So I go to letter C there. Could I use 4 as a tidal volume, 4 mils? No, because it's less than 8, right? So I can't use letter C. Can I use letter D? Well, I can use 8. That's the lower end, so that would be okay. How about this rate of 15? Well, that's too low. It's less than 20, so no, I couldn't use that, all right? So the only one that's got everything in it that I could use according to my little scrap piece of paper down here is letter B. All right, and so that's the reason why letter B is correct. Okay. All right, so that is the end of phase one. So we kind of did that in two parts here, simply because I wanted to make sure this morning before we move on that we kind of reviewed how to do that, because we'll be talking about some questions later on how to do that calculation and everything. And I just want to kind of dust off some of the cobwebs for you this morning. So remember, phase one is all about, does the patient need ventilation? And then what other settings should I choose? There are 4 boxes, very important boxes in that section that you really need to know those thoroughly, all right, to be able to use them to help you through the test. So you'll know where to start and what to do and how to make a decision about whether the patient needs a ventilator or not. The other thing I want to remind you is that, remember, in phase one, I never looked at the mode. I never used, or asked myself the question, what mode should I put this person? Because it doesn't matter. What's most important are the life functions, ventilation and oxygenation. And mode has nothing to do with ventilation and oxygenation on initial setup. Okay? So now we're going to move to phase two. Phase two is caring for the patient on the ventilator. And so here we're going to talk about all the different elements of things we need to be thinking about while we're taking care of patients on the ventilator. And questions that relate to phase two typically go something like this. They typically go, you've got a patient who's already on a ventilator, and they want you to do an assessment of the patient. And so you do an assessment of the patient, and then they find out, they want to ask you is, do you want to make any changes? And so what you have to figure out in this phase is, hey, is the patient doing okay on these settings, or are they not doing okay on these settings? If they're not doing okay on these settings, then I may need to manipulate some things. I may need to change the tidal volume. I may need to change the rate. I may need to change the FiO2, the PEEP, whatever, or even the mode. Okay, so this is kind of a little bit different thought process. And again, that's why we kind of teach mechanical ventilation in phases. Phase one, the thought process is, do I need mechanical ventilation? And if I do, what setting should I put them on? Phase two is, the patient's on the ventilator. Is the patient doing okay? And if they're not, what's the problem? What do I do to fix it? All right? So let's start off on page 14, top of page 14. And under Roman numeral 5 there, phase 2, letter A, monitoring. All of those things that are listed there as far as what you should monitor on the patient are very important. All the vital signs that are there, blood pressure, temperature, heart rate, breath sounds, CBC, blood gases, hemodynamics, that's all important. Number 2, measurements taken with the patient spontaneously breathing, monitoring spontaneous tidal volume, respiratory rate, minute ventilation, body capacity, MIP, and all those are important, okay? Those are all things that we should be looking at and understand what they mean whenever we evaluate them, okay? So that's pretty straightforward. Drop down to number 3 there, measurements taken during ventilatory support, okay? If you drop down under number 3, highlight letter C, minute ventilation. We want to make sure that you know how to do minute ventilation because they may ask you to do this calculation on the test. So again, remember, minute ventilation is simply the tidal volume times the frequency or the rate or number of breaths that the patient is getting, okay? Highlight letter E, alveolar minute ventilation. Here again, they may ask you to calculate alveolar ventilation, and the reason you would calculate alveolar ventilation is because you would be wanting to know how much of your tidal volume is actually getting down to the alveoli. That's where the effective ventilation is going to be taking place. And so the formula for that, again, is you got to take your tidal volume, subtract out your dead space, and then multiply that times your rate. But where do we get this dead space number from? Well, if you see under number 2 there, under letter E, you're going to estimate your dead space by 1 mil per pound of body weight, an ideal body weight, actually, okay? So if a person weighs, their ideal body weight is 150 pounds, then this number right here is going to be 150. You're going to take away 150 cc's out of this tidal volume, okay? And we've got an example here. This is not in the book, so I mean, if you want to take a picture of it when we go through it, I mean, or a screenshot, I mean, that's perfectly fine. So we've got a 68 kilogram patient, weighs 150 pounds. Patients receive mechanical ventilation at a tidal volume of 600 and a rate of 10. And then the question is, what is the patient's minute volume? Well, if we just want plain minute volume, we're just going to take tidal volume right here, okay, times the rate, and put that there, multiply those two together, that gives us 6,000 mils or 6 liters per minute. However, what if we take the same patient and they ask us, well, what is the patient's alveolar minute volume? Well, we've got an extra step there. We've got to find out how much dead space to take away from the tidal volume. So once again, the tidal volume goes here. Here's our tidal volume. It comes at the beginning. Now we got to go find where the dead space is. Well, this is the only weight they give us, so we have to assume this is ideal. So I'm going to take that 150 pounds. It's 150 cc's per pound. So that means I've got 150 cc's of ventilation that's not getting down to the alveoli. I'm going to put it right here in my formula, take that away from my tidal volume, and then I'll take that number, which is going to be 450, right? 600 minus 150 is 450. I'm going to take the 450 and multiply that times 10. That's going to give me the 4,500 or the 4.5 liters. So sometimes they may give you minute ventilation in mils per minute. Sometimes they may express it in liters per minute. You need to know how to be able to do both of those. Okay. All right. So that is minute ventilation. Oh, I forgot I put this in here. I forgot I added mine. So that's where that 150s come from. That's looking at my dead space. All right. I forgot I had updated that slide. Sorry. All right. So that takes us over to the top of page 15. And what we're going to talk about here in letter G is in a box, and this relates to calculations for dynamic compliance and static compliance. I think most everybody knows how to do that. So that's something you probably have had in school, just remember that the normal value for lung compliance should be letter B there under the box, between 60 to 100 mils per centimeter of water, right? But that's definitely a calculation that you may have to make on this test, so make sure. It's an easy one. Everybody, like I said, is generally familiar with it. Okay, that brings us down to number 3 there, middle of page 15. Increasing airway pressure. Sometimes the airway pressures go up on mechanically ventilated patients, and we need to know why they are going up. And highlight letter A there. If you see this increase in airway pressure, it indicates that the lung is becoming more difficult to ventilate. So that's an important thing to remember. And then letter B, there's 2 reasons for the airway pressure to increase during mechanical ventilation. And so this next piece we put in a box because obviously this is very important. All right. So the first cause for an increasing airway pressure is an increase in airway resistance. All right. And that would be seen by letter C there. Okay, an increase in peak inspiratory pressure. And letter D, the plateau pressure usually is going to remain constant. And if you actually calculate the airway resistance, taking the PIP and subtracting the plateau pressure, then that would show you that there's typically no change. Okay, so some common causes for increased airway resistance. Letter F there are secretions in the airway and bronchospasm. All right. Remember that with secretions in the airway, you would pick those up by sounds like crackles, rhonchi, things like that, right? Letter G, the treatment for increased airway resistance is the first thing there would be to suction if they've got secretions is the problem, or give them a bronchodilator if bronchospasm is the problem, okay? So that's how we fix airway resistance problems. The next thing that can cause an increase in airway pressure is a decreasing lung compliance, meaning the lung is getting stiffer, so it's harder to inflate, all right? So here again, highlight letter A, an increase in peak inspiratory pressure. You would see that with a decreasing static lung compliance. And then also letter B, the plateau pressure would increase as well. And some common causes of disease states that would cause a decrease or reduction in lung compliance are like atelectasis, pulmonary edema, ARDS, and pneumonia. And how would you categorize those diseases, as restrictive or obstructive? Well, they're not CBABE, so all of them have to be restrictive. All right. Letter D, as far as treatments, if we've got a decreasing lung compliance problem, then we're going to increase PEEP. And then the other thing we may do is try to treat the underlying cause. All right. Now, how may they show this to you on the test? A lot of times what they'll do on the test, they'll say, hey, this patient's got an increasing airway pressure, or they'll just give you something that looks like this. They'll say, you got a patient here, and this is the following information that's been recorded for the last several hours. What do you think's going on with the patient? Well, obviously, when we look at peak airway pressure, we see that it's going up. So something's going on, and there's only 2 things that can cause that, either increasing airway resistance or a decreasing lung compliance. So here again, we look at our static pressure. This is going to tell us what's happening to our static lung compliance. And we see that it's going up, okay? So that's obviously part of the problem here. But if you want to kind of get an eyeball on what's happening with airway resistance, you can do the calculation of PIP minus plateau. So if you take 30 and subtract 20 from it, that gives you 10. So airway resistance of 10 here at 8 o'clock, 35 minus 25, that's 10 also at 10 o'clock. And then 40 minus 30, that's 10 also. So again, airway resistance is not changing, but the compliance is changing. So the problem is, okay, airway resistance is not the problem, all right? It's staying the same. So lung compliance is decreasing. That's the problem. That's why these plateau pressures are going up, all right? So Another example, let's try that one more time. Here we got a patient, again, the peak airway pressure is going up. And again, if peak airway pressure is going up, that's a problem. What's causing it? Is it airway resistance or is it a reduction in lung compliance? So let's look at our static lung compliance here, our static pressures, plateau pressures, and we see that there's no change. Well, if there's no change in the static compliance, that means that airway resistance is the only other variable that can make the airway pressure go up. And if you look down here at the plateau pressure, the raw airway resistance calculation, you see that the numbers are increasing. And so here again, because this is stable, this is not the problem. Lung compliance is not the problem. But airway resistance is increasing. And so if airway resistance is increasing, then we need to think about suctioning or bronchodilator therapy. All right. So that's how they may present this in a question to you on the test. So they're going to give you all this information. You've got to interpret it and figure out what's wrong. Okay. But once again, anytime they give you peak pressure, plateau, and airway resistance, then you know what they're asking you. What's causing the pressure to go up, or what's causing the pressure to change, if anything.
John?
All right. Yes.
Yeah, could you just briefly review the airway resistance part of the box, the first top part of the box there where you talk about airway resistance briefly?
This one or this one?
That one.
This
just
one.
the top part of that. Yep.
Okay. So here again, this is coming from your book on page 15. All right. This is in letter C. It says that we have increasing airway resistance. We're going to see our peak inspiratory pressure go up. And letter D says that the plateau pressure in your book, the plateau pressure is going to stay the same. That's what that little arrow going across like that means. Okay. And the third item there, letter E in your book, airway resistance is going to be equal to the PIP minus the plateau. So that's how you can calculate the airway resistance to see if it's changing. Causes of airway resistance, letter F there, secretions in the airway or bronchospasm. How do we treat the common causes? Letter G there, well, if it's secretions, we suction them. If it's bronchospasm, we bronchodilate them. Okay? How's that?
That's perfect. Thank you.
All righty. Let's move on over to page 16. Let's talk about mean airway pressure. Here again, under number 4, highlight number 4 there, then also highlight letter A there, things that can control mean airway pressure. And you can highlight all 7 of those items. Okay? Any of those things there can cause mean airway pressure to change. The peak pressure, the rate, inspiratory time, peak flow rate, tidal volume, and inflation hold. I want you to, on Roman numeral 4 there, I want you to highlight the entire phrase there for PEEP. PEEP has the most influence on mean airway pressure. So again, you can see here's some PEEP being applied. That definitely increases the overall area underneath the curve, which is our mean airway pressure. And so it adds to that pressure, that total pressure or average pressure that is being exerted on the lungs. Letter C, in the middle of the page there, highlight that. Airway resistance mean airway pressure primarily affects oxygenation. So if we make changes in mean airway pressure, if we make changes in mean airway pressure, then that's going to improve our oxygenation or make changes in our oxygenation. That's why PEEP has such an impact on oxygenation, because it affects mean airway pressure. All right. So I always tell folks, when you hear the word mean airway pressure, think, oh, this is something that could impact oxygenation, because you're adding more pressure to the equation. And actually, it's the alveolar air equation. You're adding more barometric pressure. So therefore, if you increase barometric pressure, you're going to increase P big AO2. And if you increase P big AO2, then you're going to definitely increase P little AO2. if everything in the lung is working properly. Top of page 17, letter B, adjusting ventilator settings, primary controls. Number one there, the primary modes of ventilation are letter A, their assist control or AC mode. Couple things to remember about it is highlight number one, the ventilator is going to deliver a minimum number of mandatory breaths each minute. And then number two, the patient can trigger assisted breaths by decreasing pressure flow volume below the established baseline value. And because the patient can trigger a breath, it becomes easy to hyperventilate. All right, so you may want to write that beside number two there, easy for patient to hyperventilate. All right, the next primary mode there is a letter B, SIMV, synchronous mandatory ventilation. A couple things to remember about it. It is number one, it provides a minimum number of mandatory breaths each minute. Number two, it allows the patient to breathe spontaneously between mandatory breaths. Number three, it can be used with either volume control or pressure control. Number four, it provides a relatively consistent minute volume. Number five, it can be used for patients with tachypnea. In other words, rates greater than 20 to avoid hyperventilation. So you may want to put a star by number five there. Remember we said back up in under assist control that the patient could easily hyperventilate. So SIMV could be a solution to a patient who's hyperventilating in assist control mode. All right. So that may be useful. Because again, we're in phase two. And so again, if the patient's hyperventilating, we got to figure out what's wrong and figure out a way to fix it. So that could be the fix for it. Number six, achieve lower mean airway pressure than assist control. And number seven, it can be used with PEEP to reduce barotrauma. So all in all, this is kind of one that is commonly seen on the test. SIMV is commonly seen on the test. That doesn't necessarily mean you should pick it every time you see it. All right. But it is an MBRC favorite in terms of using the term or the mode, seeing it a lot on the test. All right. So those are the primary modes. And typically, those are going to be modes that you would start the patient off in. But again, in phase one, we don't worry about mode. We just put them on the ventilator. But in phase two, if they say, hey, this patient's in SIMV mode, or if they say, hey, this patient's in assist control mode, and we've got a patient that's hyperventilating, then you may want to say, all right, I need to change the mode. So phase two of mechanical ventilation, choosing a mode could be the solution, a different mode could be the solution to the problem. So mode does matter in phase two. You may want to just jot that down someplace. Mode does matter in phase two, not in phase one, but in phase two. All right. So initially, whenever they start them off on ventilation, on some of these phase two questions, they typically are in assist control or SIMV mode. Then what ends up happening, something starts going wrong and they want you to try to fix it. And so that takes us there to number two, the secondary modes of ventilation on the test. Letter A, let me just say this. Next to the word secondary modes of ventilation, number two there, I want you to write four letters. I want you to write ARDS right beside that, okay, ARDS. Because all of these secondary modes are used to try to help treat difficult situations with ARDS, all right? So letter A there, the very first one is the inverse ratio ventilation or IRV. This is definitely one that could be used for treating ARDS. Drop down to number three and highlight that. It's recommended for A, patients requiring high FiO2s greater than 60% and a PEEP greater than 15. B, high PIPs greater than 50. And C, low PaO2s, decreased lung compliance. That's a typical ARDS type patient that's just been described. Highlight number four there, the patient should be paralyzed and sedated while in this mode of breathing. All right, that's an important thing to remember. And then number five, you're going to start with an IE ratio greater than 2:1, okay, or 2:1 or greater. All right, so those are things to remember about that. Letter B is another alternative mode, secondary mode, airway pressure release ventilation, or APRV. Again, this is another option for ARDS. And drop down and highlight number 4. It improves oxygenation using lower mean airway pressures. All right, that's a good thing. Improving oxygenation with lower mean airway pressure, that's great. Highlight letter C, pressure regulated volume control, or PRVC. Again, this is another option that you could try for ARDS. And some of these, they may give you multiple options to choose, and you may have to just, look at your choice based upon, which of these have the least amount of potential risk associated with them. Like if you're having to snow the patient under all the time, that's not a good thing. If they can breathe spontaneously in a mode, then that might be a better thing. If you turn over to the top of page 18, continuing on with the secondary modes of ventilation, we've got the proportional assist, ventilation. That's another one that could be potentially used here. Again, most of these secondary modes, they're not going to ask you tons of information about how to set the patient up on these, but they just want to know, would you recommend using that to treat an ARDS situation? And the answer to that would be yes. Okay, any of these could be used for ARDS. That brings us to top of page 18, number 3, spontaneous breathing options. Highlight letter A, again, patient breathes spontaneously through the ventilator circuit with or without mandatory breaths. Highlight letter B, one mode for that is CPAP, continuous positive airway pressure. Under letter B, highlight number 2, breaths are patient triggered and cycled. Highlight number 4 may be useful for weaning. And number 5, you've got monitoring capabilities with the ventilator. So you can see what their spontaneous tidal volumes are and rates and things like that through the ventilator monitoring system. Highlight letter C, pressure support. Number 1, that's going to be helpful in overcoming resistance of the ventilator. Number 2, decrease the work of breathing in SIMV and CPAP. And then highlight number 5. You may be asked how much pressure support should you put somebody on, and the way that you figure that out is you calculate the airway resistance. So again, you're going to take, under number 5 there, you're going to take the PIP and subtract the plateau pressure. The last one there is volume support. And again, this is similar to pressure support, except it's targeting a particular volume to be delivered to the patient. All right, so those are your spontaneous breathing modes there. Let's drop down to page 18 there. I can't talk this morning. The page 18, bottom of the page, letter C, inspiratory flow patterns. Just be familiar with number 1 and 2 there, constant flow, what they are. Constant flow and decelerating flow. The MBRC doesn't really get hung up on flow patterns on this test. There's other tests that they may, kind of talk about that some. So just be familiar with what they are. Don't necessarily worry about know when to choose one versus the other. Letter D, high frequency. They do ask some questions about this one. Typically, they don't necessarily have you set somebody up with initial ventilator settings on this test, but they may actually have you make some adjustments and changes in phase 2. Okay, so that's kind of why we put it in this section here. So highlight number 1 there, it improves oxygenation in patients with severe lung injury such as ARDS. Number 2, these indications will sound very familiar to you. High inspiratory pressure, it's greater than 50. Letter B, air leak syndromes like bronchopleural fistula, pulmonary interstitial emphysema, and pneumothorax. Top of page 19, 3, this kind of describes what's going on. The gas is oscillating at very high frequencies, 3 to 15 hertz. Remember letter A, that 1 hertz is equal to about 60 cycles, okay? So they're breathing them at about 300 breaths per minute under letter B there, all right? So pretty fast respiratory rates. Highlight number 5, ventilator setting adjustments. Letter A, amplitude. That is going to be your primary control for changing CO2. So amplitude basically is the height of this waveform right here. So basically you can see if the amplitude goes up, what happened to your tidal volume size? Yeah, tidal volume got bigger, so that means you increased the size of the breath, all right? So if you increase the size of the breath, that means you're going to drive your CO2 down. Letter B, frequency, is the secondary control, okay, of CO2. Don't use it a lot. Most of the time on this ventilator, once you set your rate, you just set it there and don't change it. You just change the amplitude to make adjustments for CO2. However, they do want you to know what the effective rate is on the CO2 in this case, or in using this system. So highlight number 1 there, the lower the frequency, the higher the tidal volume. So when you start turning the rate down on high frequency, actually what happens is you give more time for more tidal volume to be delivered. So you actually increase the tidal volume when you decrease the respiratory rate, okay, or frequency. So it's kind of the opposite of conventional ventilation. So if I had a patient on conventional ventilation and they had decreased CO2, what I would want to do is decrease my respiratory rate, all right? But on the high frequency ventilator, if I had a decreased CO2 and I decreased my respiratory rate, my CO2 would go down even further, all right? So just remember, it's kind of the opposite. The frequency control has the opposite effect on CO2 than you would normally, think about it as far as conventional ventilation. Letter E there, correcting a blood gas while a patient is on a ventilator. This is a very important box, all right? Because this is basically, each one of the phases have either 1 or 2 boxes that kind of go with it that you really need to know in order to be able to manage the patient in that phase of ventilation on the test, all right? So this is the box, this is really the first big box for managing patients on the ventilator here. So when you look at, let's see here, the first thing there, number 1 there, if you want to normalize the high CO2, if it's greater than 45, then these are the things that you can do. You can do letter A, remove mechanical dead space. Letter B, increase tidal volume or PIP. Or C, increase respiratory rate. All right. Now, one of the things that I tell people is I want you to put a little star or an asterisk besides letter B. And I want you to write next to it, evaluate first. So if you're in phase 2, you want to always remember when we were choosing ventilator settings, we selected our tidal volume first, right? So in phase 2, what I encourage you to do is to double check that tidal volume, make sure it's in the proper range first. If it is, then the thing you're going to be changing is your respiratory rate, letter C. All right. On this test, a lot of times they'll have the person on the wrong tidal volume, but yet they'll offer you to change the rate in order to fix the problem with trying to normalize a high CO2. All right. Because most of us, if we're in the hospital, if we see that the patient has a bad CO2, we don't go change the tidal volume, we go change the rate typically, all right? And they know that. So resist that temptation to automatically reach for the rate knob whenever you got a high CO2 on the test. Think about your box, and the first thing you're choosing is tidal volume. So look at that tidal volume first, or PIP first, and if it's in the proper range, then look at your respiratory rate and decide if changing that would get the desired effect on the CO2 that you're looking for. If you're trying to normalize a low CO2, these are what they're going to be, your options are going to be, is first you're going to evaluate the cause. Is there any sort of hypoxemia, pain, or anything like that? If it is, of course, fix the hypoxemia. Then it says decrease the rate. and decrease the tidal volume. Now, here again, my thing is, I'm always on this test, I'm going to be looking at tidal volume first to make sure it's correct. And if it isn't, then I'm going to fix the tidal volume first. If the tidal volume is okay, then I'll change the rate. All right, so that just kind of helps me keep those steps in my mind as I go through the box of selecting ventilator settings, okay? It's always tidal volume, pressure, then frequency, right? And so if I do it that way on selecting the settings, and I do it this way in evaluating my patient while they're on the ventilator, I'm less likely to overlook something and miss something. Okay. All right, that brings us to number 3. If we got low PO2 problems, first thing we're going to do is going to go up on the FiO2 by 5 to 10% up until about 60%. Once we hit 60%, then we're going to put them on some PEEP, right? And we'll increase the PEEP by 2 to 5 centimeters until you either get acceptable oxygenation or you get some unacceptable side effects that occur, like a decreased lung compliance, decreased cardiac function, barotrauma, all those things that are listed there. All right. Now, if you want to decrease, if you have a decrease or want to decrease the high PaO2, then you're going to first decrease the FiO2 down to 60, and then you'll decrease the PEEP, just like we did before on our box there that we said earlier. Now, let me talk a little bit about PEEP here. I've got another slide in here. You don't have this one, so you're probably going to want to take a picture of this one because it kind of summarizes all the things we need to be thinking about whenever we think about PEEP, all right? I've got a little bit more information to reveal here, so I'll tell you when it's time. So just go ahead and get ready to take a screenshot or a picture with your phone. So before we put somebody on PEEP, we need to remember, we need to ask ourselves these questions. Is it safe for PEEP? And how do you know if it's safe for PEEP? Well, you have to ask yourself, is there an increased ICP? If there is greater than 20, then I don't want to put them on PEEP at that point. I need to get that ICP under control, all right? Is there any barotrauma, like a pneumo? Because if there is a pneumo, I don't want to put them on PEEP until after I got that pneumo treated, okay? The other thing is, do I have a decreased cardiac function? All right, and how am I going to know if I got a decreased cardiac function? Well, we got a list of things. Remember, we talked about indicators of cardiac output, heart rate, blood pressure, cardiac index, and looky here, y'all. I told you about those venous values, right? Remember, the SVO2 needs to be about 75%, PVO2 around 40, CVO2 about 15 volumes percent, and the CaVO2 should be 5 volumes percent. Once again, if you don't know those today, just make sure you know them before you go to the test. Because again, if the SVO2 and the PVO2 and the CVO2 are decreased, that means you have decreased cardiac output, right? Remember those venous values. I'm thinking about cardiac output. However, if my CaVO2 is decreased, that means I have an increase in cardiac output. So the CaVO2 has an indirect relationship with cardiac output. The SVO2, PVO2, and CVO2 have a direct relationship with cardiac output, okay? So now you can take a picture of that if you'd like to. All right, so here's another thing that kind of hits on the PEEP and oxygenation stuff. Again, I'll reveal all of these things and tell you when to take a picture. This is not in your book. This is just something I've kind of added in here to kind of summarize the whole picture of what we're dealing with. So if we got a patient problem, that means we got a decreased lung compliance. The solution for that is to go up on the PEEP. We've said that multiple times, okay? So I'm just re-emphasizing this. However, if we've got decreased oxygen, then our first solution is going to be to increase the FiO2 up to 60, all right? And then if that doesn't work, then we're going to go up on our PEEP. So if we have to go above 60%, that's when we're going to go up on our PEEP. Okay, so everything's revealed on the slide there. If you want to take a screenshot or picture of that, feel free to do so. Okay. So let's look at an example here. This is the phase 2 type question, okay? We've got a patient, 80 kilograms, being mechanically ventilated. He's on at the following settings. Again, I've got a list. So the first thing I'm going to do is skip the list. Next thing they give me is a blood gas, which is another list. I'm not even going to look at that. I want to find out what the question is. The question says, which of the following should the therapist recommend? So anytime they want to know a recommendation, what they're asking you is two things. What's wrong and how should it be fixed? All right. So to figure out what's wrong, I need to go back and look at my blood gas. Before I look at my blood gas, remember, I've got to look at my FiO2 to interpret my oxygenation, right? So 45%, so that's less than 60. So there's only two things that can cause hypoxemia on less than 60%. That is poor ventilation or VQ mismatch. If the problem is poor ventilation, then I'm going to give them more ventilation. If the problem is VQ mismatch, I'm going to give them more oxygen up to 60%. All right. So go to the blood gas. Automatically, I see I've got bad ventilation here. Okay. And so the problem here is poor ventilation. Now, some of you are saying, well, yeah, he's got bad oxygenation too. Yeah, he does. But this is my first priority. I've got to fix this first before I can even think about worrying about this. All right. So the problem is poor ventilation. I've got to go back over here to my ventilator now and find out why am I not ventilating this patient very well. But before I look at my answer that question, I've got to verify that I've got the right tidal volume for this guy. So he's at 80 kilograms. That's all they've given me. I have to use that. So I'm going to go ahead and calculate his tidal volume range. So 80 times 10 is 800. And then take the 800, cut it in half. That's 400. So my tidal volume range is 400 to 800. Where is he on? Whoa, man, he's way too low on his tidal volume. I need to increase his tidal volume. That's the problem. All right. Now, some of you, if you didn't look at that tidal volume first, you'd say, well, hey, we just need to go up on the rate. And notice what they give you in the answers over here. Here's the answer. We have already said what it is, increase the tidal volume. Notice they said decrease rate, but a lot of people may even overlook this decrease part and just see rate, and they say, yeah, that's the answer. I got to change the rate. So be very careful on these type of questions to make sure you check that tidal volume first to make sure that it's in an appropriate range. If it is, then you can consider changing the rate. All right. Now, that brings us over to page 20, some specific disease protocols. We've kind of touched on some of these already a little bit. The ARDSNet, number one there. A couple things to remember about that. The tidal volume is going to be a little bit smaller with the ARDS protocol. Usually start them off about 8 mils and then drop down to 6 mils, okay, per kilogram of ideal weight. Here again, for me, I'm still going to calculate, even if they have ARDS, I'm still going to calculate their initial tidal volume by 5 to 10, because that's just easy math. And I'm going to use the middle to lower end of the tidal volume range to pick a tidal volume for them, because I know I got to be careful about how big breath I give them. All right. Letter B, maintain plateau pressure less than 30. So the pressure's gone down from 35 to 30 if you're dealing with ARDS patients. And then C, consider permissive hypercapnia and subsequent respiratory acidosis. All right. Letter G, recruitment maneuvers. Highlight number 2. This is again for patient with poor compliance. And so basically it's a therapeutic technique performed if their oxygenation is not improved. Highlight number 4. Most common recruitment maneuver is to increase to a high level of PEEP for a short period of time. And so if you're on a ventilator, they may increase them from on a PEEP up to 40 for 40 seconds. Or B, increase the CPAP 20 to CPAP 20 for 20 seconds. All right. Personally, I like the 20-21 because that's John's favorite number, and then I just double it for they're on the ventilator. Number 5, If the SpO2 rises and then falls, you want to consider repeating the recruitment maneuver. Make sure you note that, because that's an important thing, because they may give you a situation where your recruitment maneuver did not work, so you may have to do it again. Letter H, proning position. Number 1, proning position again is placing the patient face down in the bed, and by doing this, you could actually increase the PO2 by 10 to 50 torr and reduce the shunting by 12 to 25%. So that's pretty significant. Number 2, proning should be considered for patients with ALI and ARDS when an FiO2 is greater than 60% and the PEEP is greater than 12, or when B, recruitment maneuvers have failed. All right. Number 4, proning may also decrease the CO2. Number 5, immediately following proning, you may see some transient hypoxemia. It's usually short-lived, but you just have to kind of monitor it carefully. If it doesn't improve, then you're going to have to put them back on their back again. Number 6, if proning causes hemodynamic compromise or worsening of your blood gas, then you got to put them back in the supine position. So it's all about patient response. If you do something that's to try to help the patient and they have a bad response, go back to where you were before. All right. All right, that brings us over to page 20. 21, sorry. Ventilator graphics. That first part there, the purpose, terminology, 3, waveform, I'm going to let you kind of read down through that. That's just a good review for you. I'm going to start right there at the bottom of page number 4, normal graphics. And so we've given you some illustrations of what normal ventilator graphics should look like for a spontaneously breathing patient, for an assisted breathing patient, and for a patient who's just getting a mandatory breath. Just keep in mind this little fishtail right here. Remember that what makes that is when the patient takes a breath back into the negative area here to trigger the breath, and then the assisted breath kicks in and it delivers the breath, the positive pressure breath to the patient. So that's why it makes that fishtail mark there. Here, the machine is actually triggering the breath. The patient doesn't, it's not even watching what the patient's doing. All right. So be familiar with those. On page 22, we've got a number of graphics here that we're going to kind of run through that will describe for you a problem, and then what you should do to fix it is directly underneath the graph, right? So all of these are important. So as we go through them, just highlight each one of them, and then you can highlight the bullet points that are underneath the graph to explain them. I'm going to kind of do it on the fly without doing too much reading of what's under the graph or under in the study guide. Makes it a little bit easier for me to kind of flow through these. Okay, so the first one here, we got a problem. And the problem is that we've got pressure that is building up, okay, but there's no volume going into the patient. So that's what's referred to as a lower inflection point, all right? And so at this point, whenever the pressure reaches 10 centimeters of water, that's when the volume is actually going into the patient. You see a rise in the volume here, all right? So that's definitely a problem. That means that we've got an issue with inflating the lung. Well, how do we fix that issue of inflating the lung in this situation? Well, the solution is to put them on some PEEP. So you see, here's 0 PEEP. This is 10 of PEEP on this diagram, on this graphic. So you start them on 10 of PEEP and notice that immediately once the breath starts being delivered, volume is going up. And so that's what you want, okay? The next one, letter B there on page 22. Again, most of us recognize this beak situation here on the volume pressure curve, meaning that we have overinflated the lung with either too much pressure or too much volume. And so what we need to do here is back off on the tidal volume or pressure, and then that beak goes away. All right, and again, that's described in 1 and 2 underneath the diagram there. So just highlight both 1 and 2 under the diagram. Top of page 23, letter C, here we've got a situation where we've got a volume pressure curve that's laying more horizontal, all right? And that means that we've got bad lung compliance. So to improve lung compliance, we said we always have to increase PEEP. And so what we've done is we've gone from 0 PEEP up to 10 of PEEP. And when we did that, notice what happened to the slope of the line of the curve, okay? it actually became more vertical. And whenever you've got this curve being more at a 45-degree angle, that would be representative of better lung compliance or improved lung compliance. So you went from this more horizontal to more vertical. That's a good thing. And that's described there under 1 and 2 as well. Middle of page 23, letter D, treating airway resistance problems. We've already mentioned this once before in pulmonary functions. When you see a scooped out curve, that typically means an increase in resistance. Here we have a situation that could mean that we've got bronchospasm that's going on. And so we give them a bronchodilator. Once we give them a bronchodilator and suction them, now it's a nice bigger curve. There's no scooped out portion here, and problem has been solved. Once again, highlight letter A and B underneath those diagrams. Page 24. This one's always an easy one to figure out. Leak problems. Anytime you see a loop that has an opening in it, think about a bucket. That's a leak, all right? And so basically, either the circuit's leaking or the patient connection's leaking or the endotracheal tube cuff is leaking. Those are all examples of things that could create the leak. So highlight number 1 underneath that one. Loops with holes in them or have leaks in them. Bottom of page 24, letter F. This is a situation where you have the patient is given a mechanical breath, and when they exhale out, you see these oscillations during exhalation. That's usually representative of water in the expiratory tubing. And so the solution to that, of course, is to empty the water out of the tubing. Don't dump it down the patient, though. Dump it out of the circuit, all right? Or better yet, if you've got water traps, that's a better way of taking care of that problem. So letter numbers 1 and 2 underneath that illustration. Top of page 25, auto PEEP or air trapping. Here again, this is a situation where what we should see happen in a normal condition is that this line right here should continue up where the red is and should reach the baseline and have a slight pause before the next breath. But what we actually see happening here is that we've got the breath starting before all of the breath is out of the patient. So we still have expiratory flow coming out when the next breath is given. So that's basically what we refer to as auto PEEP or air trapping. And under number 4 there, under the graph there, those are all names that could be used on the TMC to represent air trapping. And I'll be honest with you, most of the time they don't use the term air trapping on the test. I like to use terms like letter A there, dynamic hyperinflation. So highlight that one. Letter B, air trapping, very seldom. Letter C, intrinsic PEEP. They like that one. Letter D, inadvertent PEEP. They like that one. Or E, occult PEEP. I don't know. They may even use sneaky PEEP on there. But they typically are not going to say air trapping on the test, typically. Okay? But again, the solution to all of that is number 6, is you got to give them more time to exhale. And so all of those things listed under number 6 there, I would highlight A through E. All those things are things that can be done to fix the dynamic hyperinflation or intrinsic PEEP problem. And that's what they're going to be expecting you to do, is how to fix it. Not only recognize it, but know how to fix it. Okay. Top of page 26, patient ventilator asynchrony. Here's a situation where you've got the patient is trying to take a breath in but can't, assist a breath in and can't, assist, can't, and then they pull real hard and then they trigger the breath. Well, obviously they're having to pull too hard to trigger this breath, so we don't have our sensitivity set sensitive enough for the patient, so we need to adjust our sensitivity, and that's highlight letter B at the bottom of page 26 there. The correction for that problem is to adjust the trigger setting. Top of page 27, auto trigger, auto cycling. Here again, this is another problem with sensitivity. It's too sensitive, that it's automatically turning on. So again, highlight letter C under that diagram. Correction is to recognize and adjust the trigger sensitivity. Flow asynchrony, letter B in the middle of page 27. Here again, anytime you see something that's scooped out on a pressure time curve, that means you don't have enough flow going to the patient. And so you need to correct it by doing number 3 there above the graph where it says increasing the flow, decreasing inspiratory time, or increasing expiratory time. Those are things to correct that problem. All right, that brings us to drugs, pharmacology. And I know some of you are saying, man, I need some of these about now. John, it's filling my head full of all this craziness. Well, once again, pharmacology on the test, you just need to be familiar with some examples of drugs, what they are, and when you would use them. So you don't have to know drug dosages. So let's take a look at these on page 28. Highlight number 2, sedatives. We've already talked about these. These decrease anxiety, promote relaxation, and these are our LAMs and PAMs. So I would write that next to them, LAMs and PAMs. So anything that ends in LAM or PAM, that's going to help reduce anxiety and make you relax. All right. Highlight number 3, anesthetics. These reduces the patient's ability to perceive sensation. And highlight letter A, propofol. Thing to remember about this one, it's a very short acting. There's no antidote, and whenever you want to reverse this anesthetic agent, you just turn the drip off. And once you turn it off, they start waking up. Number 4, analgesics reduce the sensation of pain. And there's all of our narcotic agents there. So morphine, codeine, mepridine, fentanyl, hydromorphone, oxycodone, hydrocodone. All of those are things that are going to reduce the pain. Now remember, the thing to reverse these, if they overdose on them, is the drug naloxone. 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 You know it, or probably know it as Narcan, but they won't use the term Narcan on the test because they know that you're probably familiar with that one. Number 5, neuromuscular blocking agents. These are ones that we may have to use in order to, paralyze the patient so that we can use some of those, like inverse eye ratio ventilation. So these are all the things that end in uronium. Anything that's uronium is typically a neuromuscular blocking agent. Now there's one that's missing in there, and that's the succinylcholine. And the reason we don't use succinylcholine, we use that for intubating because it's short acting, and it's probably, these are longer acting agents, so we don't have to give it as frequently. All right, so that brings us over to page 39. Now we move into phase 3. So phase 2 is taking care of the patient while they're on the ventilator and identifying problems and fixing those problems. Phase 3 is getting them off the ventilator. And if you've done your work like you were supposed to on phase 1 and then learned the box about bedside ventilatory parameters on page 29, you see we've got another box there. It is also very important, okay? And you need to know it just as well as the box in the previous chapter, or in phase 1, and notice that is basically the same information in the acceptable column that you've already learned. However, there's one thing that's been added to this box that's not in the previous box that you've already learned, and that is the rapid shallow breathing index at the top row there. Make sure you highlight that and make sure you know that it's the normal value or acceptable range for that is less than 100. So if the patient is able to do any of these items listed here, at the rates between 8 to 20, body capacity greater than 10 mils per kilogram, minute ventilation less than 10, spontaneous tidal volume greater than 5, MIP is less than or greater than minus 20, and MEP greater than 40, then they're ready to be weaned, okay? So the other things are these, number 3 there, highlight it, the clinical measurements. And again, I would highlight letter B, the shunt should be less than 20%, and the VD to VT should be less than 60%, all right? And then highlight number 4. You need to verify that the underlying disease process has been reversed. So basically, if all of these things are good, then we can move forward towards liberating from the ventilator. However, if there are 2 to 3 of these things that are bad, then we probably won't. And again, a lot of people ask the question, well, John, what if there's only one thing that's bad? Usually on this test, they're going to give you multiple things that are bad. So you don't have to worry about being on the fence. It's usually going to be very clear as to whether or not they're ready to come off or not. Top of page 30, spontaneous breathing trial. This is the best method for evaluating weaning. Highlight number 1. Number 2, administer CPAP. Could be administered with CPAP or without pressure support, with or without pressure support. Number 3, the minimum trial of 30 minutes. 4, maximum trial of 2 hours. Number 5, criteria for termination of spontaneous breathing trial. If any of those things listed there, A through G, occur, you're going to stop the trial. If the respiratory rate is greater than 35, you're going to stop. Heart rate greater than 130, stop the trial. Cardiac arrhythmia, stop the trial. Change in blood pressure, if the systolic pressure gets greater than 180 or less than 90, you're going to stop the trial. Letter E, if you have excessive anxiety, stop the trial. If you have a pulse ox sat go below 90, you're going to stop the trial. pH less than 7.30, you'll stop the trial. And number 6 is very important because when you stop the trial, you're going to return the patient to mechanical ventilation for a full 24 hours. All right, so you're going to rest them overnight. You're not going to attempt the trial later in the day. So highlight letters A and B. Letter C, weaning methods. Any of those would be appropriate. 1 through 5, they don't necessarily have one preference over the other. Letter D, drugs that could be used during to suppress ventilation should be discontinued. We got those listed there for you. Highlight letter E. Remember, you should explain the process and reassure the patient that he or she is going to be monitored closely. Assessment of the patient, top of page 31, assessment of the patient during weaning. I'll let you kind of read down through that. Letter G, care of the patient, or the ventilator-dependent patients. I want you to highlight number 1. If they're on the ventilator or after 3 months of failed attempt weanings, then they would be considered to be ventilator-dependent. Highlight number 3, patients may be transferred to a subacute or long-term care facilities. And number 5, if a patient cannot be weaned, the goal should be to restore the patient to the highest possible level of independent function. And you can kind of read down through the rest of those on that page. All right, that brings us to the last piece here, which is non-invasive positive pressure ventilation. Let me just caution you about this. Most of us are used to seeing patients in the hospital. They come in, they can't oxygenate. We try the oxygen systems. If the oxygen systems don't work, then they go to non-invasive, and then non-invasive to mechanical ventilation. On this test, that's typically not what happens, right? They're going to give you very specific conditions or situations in which this non-invasive is indicated, all right? And we listed those for you on the top of page 32. So under letter B there, highlight number 1. These are the conditions or situations in which you're going to use non-invasive on this test. Number 1, acute exacerbation of chronic respiratory failure. So again, if you got a patient who's got COPD and they're leaning towards being put on a ventilator, you're going to use this first before you put them on an acute ventilator, okay, or an invasive ventilator. Number 2, congestive heart failure or pulmonary edema would be 1. Again, this is kind of a stopgap measure until you can maybe diurese and get some fluid off the lungs and not have to intubate them and put them on an invasive ventilator. Number 3, severe dyspnea and do not intubate. So if a person has a DNI order and they're having difficulty breathing, you can use this as a measure to provide comfort and alleviate some dyspnea. Those are the only 3 reasons on this test that they would allow you to put somebody on a non-invasive positive pressure ventilator. So keep that in mind. Letter C, contraindications. Highlight number 3, if they're unable to protect their airway. Letter A, that could be an aspiration risk, or B, dysphagia. Number 4, if they're unable to clear their secretions, that's another reason. Drop down to letter E, patient interface considerations. Number 1 would be a mask. is the most common. Again, make sure the mask fits. And then letter F is important. You need to know how to pick initial settings for non-invasive, and these would be the ranges. So initial IPAP range would be 8 to 12, and initial EPAP range would be 4 to 6. Remember, IPAP is going to determine the size of the breath. EPAP is going to be like PEEP and affect your oxygenation. Okay? So on the top of the next page there, we have some practice questions for non-invasive. So let's look at those. The first one there says, a patient is receiving non-invasive positive pressure ventilation by mask. The current settings on arterial blood gases results are as follows. So I got a list. I'm going to skip that. I've got a blood gas. I'm going to skip that. And it says, which of the following should the therapist recommend? Okay, so what is the problem? Well, the problem is with the CO2. When I go back and look at my blood gas, all right? So I look at CO2 first on the blood gas, as always. It's 56. So I got a problem with ventilation. So I need to improve ventilation on this patient. How am I going to improve ventilation with BiPAP? I mean, not BiPAP, but non-invasive. That's the other thing. They never use the term BiPAP on the test, by the way. It's always non-invasive. So if you, I kind of did a little slip there by saying BiPAP. They don't use the term BiPAP. They use the term NPPV or non-invasive ventilation. So on this blood gas, we've got low ventilation. So how are we going to fix that? Well, remember we said that the IPAP is what changes tidal volume. So I need to go up on my pressure. All right, so he's on an IPAP of 15. I need to go up to probably about 20. And you see they give you two options there. A, going up to 20, or B, going up to 25. Well, usually you don't go up on pressure that much. Usually the height you're going to go up on a pressure is 5. Okay. So that's how we would fix that problem. Number 2 says the patient's receiving non-invasive positive pressure ventilation by mask. Current settings, again, I got a list I'm going to skip. They want to know what I should recommend. So before I recommend, I got to go back and find out what the problem is. To find a problem, I got to look at my blood gas. When I look at my blood gas, and this is an interesting one here, the CO2 looks good, all right? In order to interpret my PO2, I got to look at my FiO2, right? Do they give me an FiO2? No, they don't. So, I mean, don't freak out if they don't give it to you, because if they don't give you something, it just means that it's not that important to answer the question, all right? So, I've got a bad PO2. So what do I need to do to fix my oxygenation? Well, to fix oxygenation, I need to change my EPAP, right? So that's the thing I want to go up on is my EPAP. But they don't give me the option of increasing my EPAP alone in my answers down under A, B, C, D. Now I have to pick 2. And so remember, if you go up on your EPAP, and if you will, just kind of follow my mouse right here on the screen. Let's say that the EPAP is right here, okay? And this is the IPAP level right up here at the top line. If you go up on your EPAP to right about here, what happened to the size of the breath? Yeah, it got smaller. So if you go up on your EPAP, you've also got to go up on your IPAP in order to keep the distance between those two pressures the same, to keep your tidal volume the same. So that's why 1 and 2, letter B, is going to be the correct answers, because you're keeping a pressure differential of 10 centimeters between the EPAP and IPAP. All right, because again, if you look up at the top there, under the example 15 and 5, the difference between those two is 10, right? So you got to keep the difference between IPAP and EPAP at 10 to keep the breath size the same. So if we go up on EPAP to 10, that means we got to go up 5 more on our IPAP as well. Okay. All right, let's do a few of these practice questions, and then we're going to let you guys take a quick break. Man, it's 12:27. Whew. That took a lot longer than I thought. All right. So let's see here. Let's do these questions first before we go to break, because I think that'll make it a lot easier instead of losing our train of thought. We get to re-emphasize some things here. Okay. I understand if you got to get up and go, nature calls, just go ahead and do what you need to do. But we're going to push through these until and then we'll take probably about a 15-minute break. All right. So practice question number 1 here. You don't have these in the book, so here again, I wouldn't worry about copying them because there's other practice questions you can look at. This is just the main thing I want you to do here is to walk with me through the steps of how you would address this question and work through this question on the exam. So after an appropriate tidal volume and frequency are determined for a patient receiving mechanical ventilation, the respiratory therapist evaluates the patient's breath sounds. Adequate breath sounds are not heard in all areas of the lungs before inspiration. So if I don't have breath sounds, that means I don't have good airflow into the lungs. And they want to know what action I should take. All right. And so here's a question. Whoa, man, this is crazy. I've never seen one like this before, right? So when you see this type of thing with the A, B, C, D, yes, no, don't get freaked out about that. The first thing you want to do when you see that question is zero in on this top row. That's where you want to focus your attention, okay? So again, what is the problem with the patient? The patient has reduced airflow into the lungs. So basically, you probably got bad distribution of ventilation. So what are things that we can do to improve the distribution of ventilation? Well, could I decrease inspiratory flow? Most people will say no, but let's think back to our breathing pattern, our standard breathing pattern during our treatments. How do we tell the patient to breathe? Take a nice, slow, deep breath. Slow breathing improves deposition and distribution of ventilation. So yeah, this would be something that could be helpful, okay? Decreasing the inspiratory flow. Activating the inspiratory hold. Well, once again, with our therapy breath, we always tell the patient to hold at the end of the breath, and that's to improve distribution of ventilation. So yeah, this could be helpful also. But do we ever tell our patients during therapy to breathe real fast? No, that's not conducive to good distribution of ventilation. So the two things that will cause or improve distribution of ventilation are these first two things. So I'm looking for an answer that says yes, yes, no. Where is my yes, yes, no? It's letter C. So that's the one that I would pick there, okay? Practice question 2, during a spontaneous breathing trial. So this patient must be in phase 3. They're trying to see if they're ready to come off the ventilator. We've got a 70-kilogram adult patient. They're receiving 45% oxygen via T-piece, and the following data are measured and recorded. Okay, I got a list. I'm going to skip it. They want to know what I should do. So before I know what I should do, I should go back and look at my blood gas. Well, there's no blood gas, so they lied to me at Kettering, right? No. Just remember, use the information they've given you. This is a spontaneous breathing trial. And so what they've done here is they've shown you some data at 9 o'clock and data at 9:20. And let's compare the data to see if the patient's getting better or worse as time goes on. So here they started with the respiratory rate of 14. Now they're at 24. That's not good. Heart rate of 82, and then it went to 120. That's not good. Blood pressure 110 over 70. Now it's 140 over 100. That's not good. Tidal volume at 400 cc's or 4.4 liters. And now it's gone down to 0.2 liters. That's not good. And the vital capacity has also gone down. So everything has gone down. Everything looks bad. So what we need to do is we need to put them back on the ventilator. Okay? So the answer is going to be right here. Resume mechanical ventilation. They failed the spontaneous breathing trial. All right. Question number 3, which of the following drugs would best fight pain and control ventilation for a patient receiving mechanical ventilation? Well, obviously, we're looking for something. We're looking for something that does both. The LAM and PAM, that just sedates. It doesn't do anything for pain. This is a paralytic agent, right? Now, morphine can do something for pain and cause you to sedate, right? So that's probably going to be the best answer. Succinylcholine is just a paralytic. All right, so that would be how you would approach that question. 75-kilogram man receives postoperative mechanical ventilation at the following settings. Again, I've got a list. I'm going to skip the list, go to the next thing. Got a blood gas. I'm going to skip that, go to the question. They want to know what I should do. Before I know what I should do, I've got to go back and look at my blood gas. Before I look at my blood gas, though, I've got to know my FiO2, right? So my FiO2 is 60. So again, that's a red flag. FiO2 over 60, that means that I've got could have some serious issues with oxygenation, and it's probably shunting, venous admixture, or refractory hypoxemia, right? I look at my CO2. I'm kind of ventilating a little bit much here. The PO2 is at 128, so that's pretty high. So obviously my ventilator settings may not be properly set, but again, my first priority here is this ventilation, right? So I need to fix that first. So go back and look at my settings, but before I look at my settings, I need to calculate what my estimated tidal volume should be for this guy. He's 75 kilograms. So I'm coming down here, taking 75, multiplying it times 10. That equals 750. That's my upper limit. Take the 750. I'm going to cut it in half. That's 375. And so now I have my range, and I see that my tidal volume is what? Too high. Okay. Here's where I just listed all the other settings that he should be on. All right. When I go back over here to my question, I know that I'm going to be looking at decreasing my tidal volume. That's the problem. The tidal volume was too high. Okay. Not going to change my rate because, again, the tidal volume is the first thing that I want to make sure is correct. And if it's not correct, I want to fix it. Because that's the first thing I choose whenever I'm selecting my ventilator settings. Question number 5. Got an 18-year-old, 80 kilograms, 176 with a closed head injury. Ooh, okay, so I got to be concerned about ICP. Receives the mechanical ventilation at the following settings. Again, I've got a list. I'm going to skip that. Another list. I'm going to skip that, and they want to know what I should do. So I got to figure out, hey, how's the patient doing on mechanical ventilation? So I go back to my blood gas. Before I look at my blood gas, though, I got to look at my FiO2. Okay, well, he's on FiO2 of 35, so that's good. Let's go back over here. My CO2 is at 33, which is low, but again, this is a head trauma patient, so that may not be all that bad. My PO2 is at 95, so that's fine. My pH, of course, is elevated, but that's because I'm hyperventilating here. But notice that they give me something else down here. They give me ICP of 35. Where should my ICP be less than? John's favorite number. Should be less than 20. So I need to probably ventilate a little bit more or to give some mannitol. All right. So that's what the problem is with this guy. So what do they offer me here? They say maintain current settings. No, I don't want to do that. If I add dead space, that's going to make the CO2 go up. I don't want that. Provide manual hyperventilation. Ugh, I don't want to do that. Repeat a blood gas. I don't want to do that either. But the closest thing that says something about changing and hyperventilating more is C. So that's the one that I'm really left with. I've got to pick that one. That's the only one that deals with the ventilation, the hyperventilation issue. Okay. Question 6. Here we've got a patient who's 60 kilograms with bilateral pneumonia, and they're on the following settings. So again, I've got a list. I'm going to skip that. Good. Blood gas, I'm going to skip that, and they want to know what I should do. So I need to go back to my blood gas. Oops, I'm going the wrong way. Go back to my blood gas. Before I look at my blood gas, I need to look at my FiO2. He's on 40%, so that's less than 60, so that's a good thing. Come back over here. Look at my CO2. Okay, he's hyperventilating. All right, and he's at 95, so that's okay. So basically, I'm ventilating too much here. So I got to figure out, why am I ventilating too much? Where should my settings be? So So I come back over here, he's at 60 kilograms. My range for that guy should be 60 times 10, that'd be 600, and then cut that in half, that's 300. So that's the tidal volume that he should be on. But he's not being ventilated with tidal volume, so I don't have to worry about that. He's being ventilated with pressure. It's less than 35, so this is okay. All right. And because that's okay, that's great. The mandatory rate is 12. Well, he's being hyperventilated. And not only that, but look at the total rate here. He's breathing a number of breaths over 12. So he's actually in assist control and he's got a hyperventilation situation going on here. Does this sound familiar? Hyperventilation assist control? What do I do to fix hyperventilation and assist control? Have to change them to a different mode. What mode should I change them to? SIMB, all right? So again, this is a situation where you're looking at all the information here that they give you. It's going to point you at changing the mode as opposed to changing a rate. All right, and so again, that would be the correct answer here. Would be initiating. Again, CPAP's not going to fix this problem. Increasing the FiO2 is not going to fix the CO2 problem. Decreasing the mandatory rate would, but the fact that he's hyperventilating is not going to change it, because if you decrease his mandatory rate, okay, he's still going to be assisting with assist control. He's going to be triggering breaths. Okay, so that won't fix the problem here. All right. Question 7, 85 kilogram post-CABG patient on the vent. Got a list. Another list. They want to know what I should do. So I'm going to go back to my blood gas. Before I look at my blood gas, I'm going to look at my FiO2. I'm on 40, so that's less than 60. That's good. Come back to my blood gas. Oh, I'm not ventilating. Why am I not ventilating? Let's look back and see if my settings are where they're supposed to be. So 85 kilograms, I multiply that times 10, that gives me 850. Cut the 850 in half, that gives me 425. So 425 to 850 is the tidal volume he should be on. What's he on? Oh, his tidal volume is too low. So the answer to this is going to be to increase his tidal volume. And that's what they offer me there on letter B. Okay. All right. So real quickly, we're going to run through the pre-test questions at the beginning of the book there. Starting with number 21. And the parameter that starts the inspiratory phase of the positive pressure breath is referred to as the trigger. Yes, most of you got that probably pretty easily. The next one here, while evaluating a patient receiving mechanical ventilation, the respiratory therapist observes persistent high pressure alarm. Which of the following could cause this situation? Obviously, this is going to be high pressure, probably excessive secretions. This would cause a low pressure, this would cause low pressure, and this would cause low pressure, but this would cause a high pressure. Okay. Top of page 9, there's that favorite graph we like to look at. While the patient's on mechanical ventilation, the therapist reserves the following airway graphic. Now again, they give you the graphic, you look at it and you see, okay, yeah, he's got dynamic hyperinflation, right? And what should we do to fix it? Or they're saying the question is, what situation can cause the air trapping or the dynamic hyperinflation? So again, when you got a question like this, skip the yes, no stuff down here, look at the top and answer yes, no to each one of these. Can bronchospasm cause an increase in air trapping? Absolutely. Can retain secretions? Absolutely. Can excessive expiratory time? No, that's what you want to do is give them more time to exhale out. So that would not be it. And then reduce lung compliance. No, reduce lung compliance, the air comes out much faster. So you don't usually have a problem with air trapping in those situations. So we're looking for an answer that says yes, yes, no, no. And where is that? That would be C right here. Yes, yes, no, no. Right? So that's how you'd approach that one. Number 24, which of the following would be the most appropriate initial ventilator settings for a patient receiving recently intubated for myasthenia gravis? They are 5'10" and weigh 154 pounds or 70 kilograms. And so we go down here and they want you to choose ventilator settings. So the ventilator settings, by looking at the patient, our tidal volume range, since they are at 70 kilograms, 70 times 10 is 700 on the upper limit. Then I cut my upper limit in half. That's 350. So there's my tidal volume range they should be on. Their peak pressure, if I'm ventilating with pressure, should be less than 35. And then my frequency should be 10 to 20. I'll start them off on an FiO2 since they haven't told me they're on the ventilator or on oxygen. I'll start them off on oxygen, range between 40 to 60, and then the PEEP 4 to 6. Right? So I'll go to my first one up here. Could I use this pressure? No, that's too much. It's over 35. Could I use this tidal volume? Yeah, because it's between the 350 and 700. So I could use that. Could I use the 15 rate? Yeah, it's between 10 and 20. Could I use the 50%? Yeah, it's between 40 and 60. Could I use the 4 a PEEP? And I would say yes. So this would be the one that I would pick. Okay. And again, if you look at these others, 30 would work as a pressure. The frequency of 12 would work, but the 65 is too high. Right. The tidal volume 600, that's too, it would be acceptable. Rate of 13 would be okay. The 45 FiO2 would be okay, but in this case down here, the PEEP is too high. Remember, there's only going to be one correct answer. Okay. Question 25. 80 kilogram patient intensive care unit following aortic valve replacement surgery receives mechanical ventilation. The ventilator settings are as follows. I got a list. I'm going to skip the first list. Got another list with a blood gas. I'm going to skip that. And they want to know what I should do. So to find out what I should do, I come back to my blood gas. But before I look at my blood gas, I need to look at my FiO2, right? 65. So that could be a problem. This person may have a shunt going on, and I may have to do something with my PEEP, okay? But getting ahead of ourselves, let's go back to the blood gas and look at the blood gas. First thing I look at is CO2. Well, it says I'm not ventilating, all right? Well, if I'm not ventilating, then I got to figure out from my settings if they are correct or not. And again, I've got an 800 kilogram patient. So when I calculate, take the 80 kilogram patient, when I multiply it times 10, that's going to give me 800 for my upper limit tidal volume. Cut it in half, that's 400. Okay. I see that my tidal volume is in the proper range. Okay. Not ventilating with pressure, and I'm in the proper range for my frequency, but I need to do something to improve my ventilation. So since my tidal volume is appropriate, the other option I have to change CO2 is going to be my rate. So I need to increase my respiratory rate for this patient. So that's what I need to do for this guy. Come back over here, and I'm looking for the thing that says increase the frequency. There we go. Okay, and that would be correct. All right, bonus question, and then we take a break. The complication illustrated in this photo, in case you did not know, that is auto PEEP. All right, so let's take a break here. I know that was kind of a long session, but I wanted to get through that without breaking it up if I could. I just, okay. So I've got about 10 till, let's come back about 5 minutes past the hour. I'll give you a little extra time here for the break since I went kind of long on that. And we'll start back about 5 minutes after 1 to go over the next section. Okay. And let's see, before I check out, let's see, I need to touch base with Tom. Is there anything I need to address at this point, Tom?
Nope, nothing at this point.
Okay, well, that was a mouthful. So I'll see you guys back in about 15 minutes then.
Yeah. Right. Oh, okay.
Okay, everyone, I am back. Hopefully everybody was able to get a good break in. Tom, is there anything that I need to address or talk about before we move on to the next section?
Hey John, it's Kim.
Hey.
Hey, I'm gonna be here for the next hour and a half or so. Tom's got a
right.
conference call.
That's what he was telling me, yes.
Yeah, okay. And nothing so far, so we're good.
All righty, well, we'll push on ahead. We're kind of on the downhill slide now.
Okay.
All right, thanks, Kim.
You're welcome.
All right, so this next, actually these next two sections, we're going to do one right after the other. They usually take about an hour. There's a lot of variety of information in these two sections, the special procedures and the general patient care. But there's not a lot of questions on them. So usually we can kind of get through these and there's not a lot of, the number of pages is not quite as many as some of the other sections, and the content is not as difficult. So what we'll do is we'll kind of get through these two sections here, then we'll take our 30-minute lunch break, and then we'll come back and do a wrap up the session on the study guide and start working on some of the clinical simulations this afternoon. All right, so if you turn in your books to section F and turn over to page F3, you can see there's quite a long laundry list of things there. And again, fortunately, they're not going to ask you a ton of questions about these things. The main thing you have to basically know about this stuff is what is it, and how does it help you, take care of the patient, that kind of thing, when you would use it. So we'll be talking about specialty medical gases, thoracentesis, sleep apnea studies, chest tubes, chest drainage systems, cardiopulmonary stress testing, bronchoalveolar lavage, infant apnea monitoring, cardiac emergency techniques, disaster plan, medical emergency teams, patient transport, metabolic studies, and indirect telemetry and end of life. All right. On page 4, let's start up at the top there under specialty medical gases. We'll start off with letter A, hyperbaric oxygen therapy. Drop down and highlight number 2 there. Disease disorders that are frequently treated with hyperbaric. Highlight letters A, CO poisoning, and letter B, decompression sickness. So it bends. All right. Drop down to number 4. Most hyperbaric therapy is conducted at pressures between 2 to 3 atmospheres ATA. Okay. Now, remember, the CO poisoning aspect of using hyperbaric, as we mentioned before, if the carboxyhemoglobin level is greater than John's favorite number, 20, then we're going to give hyperbaric and 100% oxygen until that carboxyhemoglobin level gets below 20. All right, so that's just a FYI to kind of remind you about that. Highlight letter B, helium oxygen therapy. Highlight number 1, the purpose is to decrease the patient's work of breathing because you're delivering a less dense gas. Number 2, the indications for this would be A, post-extubation stridor, or B, severe asthma or status asthmaticus. Highlight number 3, concentrations that could be used would be 80%, 20%, 80% helium, 20% oxygen, or 70% helium and 30% oxygen. So here again, remember that if the patient needs supplemental oxygen, then you're going to give them the 70% helium, 30% oxygen. Otherwise, doing the 80-20, that's just like giving them oxygen in the amount of room air because it's only 20%. Number 4, some considerations. A, administer with a non-rebreathing mask. Letter B, when you're using a flow meter, you may have to actually calculate the actual flow because, again, the gas you're using through the flow meter is typically an oxygen flow meter. They don't have a helium flow meter to administer the gas. So the flow meter is not calibrated for this particular mixture of gas. So we give you the formula there. The actual flow is the indicated flow times a factor. And then the factors for each mixture that you may have, the 80-20 mixture, would be 1.8, and then the 70-30 mixture would be 1.6. And so here's John's estimation hat being put on again. And so since 1.8 and 1.6 are almost the number 2, all I'm going to do on the test is if they ask me to figure out what the approximate flow is going out of the helioxygen mixture through the flow meter, I'm just going to take the flow meter setting and I'm going to double it. Okay, just multiply it times 2. All right, and there's an example there, number 3. You can kind of see how that would work. So here again, you know, the 18 liters, I would have done 10 times 2, that would be 20 liters. And again, if 18 liters, their answers got to be, the other wrong answers have to be far enough away from 18 in order so that you don't pick it inadvertently. All right. Top of page 5, inhaled nitric oxide. Highlight number 1, remember this is a gas that acts as a potent pulmonary vasodilator. Number 2, indications for inhaled nitric oxide are A, primary pulmonary hypertension. Number 3, the dosage of INO, letter A, the standard initial dose is about 20 to 40 parts per million. Letter B, the dose should not exceed 80 parts per million. Highlight number 4, this is probably one of the more common areas they may ask you questions about INO, and that's with the side effects. So highlight letter A. Methemoglobin levels could increase. And again, if you got an increase in methemoglobin level, that means you're not going to have the ability to carry as much oxygen. Letter B, nitrogen dioxide levels could increase and could be toxic if they get above 10 parts per million. And then letter C, you could have rebound pulmonary hypertension. And this occurs whenever you discontinue the INO too rapidly. And so number 5 talks about how to discontinue the INO. Highlight letter A. It must be done carefully and slowly to prevent a rebound effect. Number 1, to avoid the rebound, titration is typically 20 parts per million down to 10, down to 5, and then you discontinue it. Number 2, to correct the rebound, you would return to the previous INO level. So if you were at 10 and they started showing rebound pulmonary hypertension, then you would go back up to 20, okay? And try to drop it maybe half of that to see if there's still an issue with it. All right, that's pretty much INO. Top of page 6 is thoracentesis. Remember, this can either be a diagnostic or therapeutic procedure to get fluid out of the chest. Letter C, highlight number 1, on physical exam, it will typically reveal a flat or dull percussion note. And number 2, x-ray findings, again, using the lateral decubitus, that can be helpful in determining whether or not you have fluid in the pleural space or not. And then letter D, the procedure. Number 1, the most common position for the procedure is have the patient sitting up and leaning forward. Top of page 7, analysis of the pleural fluid. Highlight letter A, transudate fluid is usually clear and has a slight straw color. That's the term they would use. Letter B, as more cells are added to the fluid tends to get cloudy or opaque, and this is referred to as exudate. So again, just knowing the difference between transudate and exudate. Then we have some disease states that you may see exudate in, and those are listed there for you, 1 through 7. You can kind of read down through those on your own. So I would highlight 1 through 7. Top of page 8, sleep apnea studies or polysomnography, highlight letter A. Again, this is a common condition where you have apnea during sleep for periods of 10 seconds or longer. Highlight letter B, there are 3 types of sleep disorders. The first one, number 1, is central apnea. This basically is just when the chest is not moving during sleep. Number 2, obstructive apnea. This is where we have chest moving, but there's no air moving in and out of the lung. And then number 3, the mixed, is a combination of central and obstructive. Highlight letter C, as far as history and presentation, number 1, the patient often will complain of daytime sleepiness and insomnia at night. Letter D, observation in the sleep lab is going to confirm the diagnosis and severity. Number 1, Letter A, while the patient's sleeping, they're going to put a chest motion sensor on them, what's also called inductive plethysmography. I would highlight that term because they may put that on the test, and you just need to know that's the device that measures chest movement. Letter B, they're going to measure nasal airflow. Letter C, pulse ox. Letter D, the number of apneas. And letter E, the number of hypopneas, or shallow breathing. Highlight number 2, the apnea hypopnea index, or AHI. Letter B is calculated by dividing the number of apneas and hypopneas by the number of hours of sleep. And we give you a table down there to show you the appropriate range. And what I would remember is the middle range there, moderate, 16 to 30. So moderate sleep apnea would be a score of 16 to 30. Less than 16 would be mild. Greater than 30 would be severe. And then on the next page there, on page 9, we have the sleep study graphs. They're not going to give you one of these, and you're not going to have to interpret it because they've got a whole test for sleep study. But this is just to remind you of how the sleep study works. So again, you can see they're monitoring airflow in 2 locations: thoracic movement, abdominal movement, and the saturation. And as you can see here, we have airflow going into and out of the body in this section here. We also have chest movement, and we have abdominal movement, which is what you're supposed to have, and the saturation is holding. It's pretty good. However, notice at this point, we stop air movement in both sensors, and we stop chest movement and abdominal movement. And that would be, and as well as that, our saturation is starting to drop as well. And so that would be an apneic episode, and it's basically a central apnea episode because basically the chest stopped moving. As opposed to the one at the bottom of page 9 there, obstructive, once again, you see air movement here, thoracic movement here, abdominal movement here, and then the saturation here. As we move on down, we see the airflow begins to stop, but yet you still have chest movement and you still have some abdominal movement. And so because basically you've got the chest, the patient's trying to breathe, that's an obstructive problem. So their airway is obstructed. And that's why they call it obstructive sleep apnea. Top of page 10, letter F, the treatment for sleep apnea. Number 1, nasal CPAP and or non-invasive. Letter A, CPAP therapy, highlight number 1. The starting pressure should be between 3 to 5. And then number 2, the CPAP is increased to eliminate any obstructive apneas, hypopneas, snoring, or oxygen desaturation. The other thing we can do to help treat sleep apnea is weight loss. Number 2, number 3, surgery. Number 4, respiratory stimulants. Number 5, tracheostomy. That's kind of a last-ditch effort. And then number 6, refer the patient and family for appropriate educational programs because patient compliance is important. You want the patient's family to be encouraging them to use their device so that they get the benefits of it. All right, that brings us over to top of page 11, and we'll talk about chest tubes here. Abnormal conditions requiring chest tubes. Under number 1 there, the pneumothorax, letter A. If we have less than a 10% pneumo, then a chest tube is not required, okay, or may not be required. However, letter B, if it's greater than John's favorite number, greater than 20%, a pneumo greater than 20%, that would usually require a chest tube. Drop down to number 3, hemothorax or pleural effusion is a reason we'd want to put a chest tube in to get air or fluid out of the chest cavity, pleural cavity. Number 4, this is important. If the patient is unstable, then we need to take immediate action to insert a large bore needle to relieve the pressure. All right. Then after we've done that, then we'll insert the chest tube. So again, this is a very important thing because oftentimes on the test, they'll give you a scenario and they'll ask you what should be done, and they'll give you 2 possible answers. One is to insert a needle, and the other one's put a chest tube in. You're going to say, well, I could do either one of those. Well, if the patient is unstable, your quickest action, your quickest way to relieve the pneumo is with a needle, large bore needle. Once you've got the air evacuated out in the situation and the patient stabilized, now you've got the opportunity to put the chest tube in place. Okay. Letter B, chest tube placement, highlight number 2. If you're going to drain air, it needs to be in the second intercostal space midclavicular line. And so again, air is going to be in this location right here on the illustration down below. And then if you're going to remove fluid, then it's going to be the mid-axillary line of the 5th and 7th intercostal space. And it's going to be, again, on the mid-axillary line, so it's going to be in the armpit here. Right? Once again, you say, well, I've never put a chest tube in. Well, that's true, but on this test, they may ask you, where should you put it? Because again, you're the only one that's taking care of the patient on the test. So just kind of keep that in mind. Top of page 12, here we got the chest drainage system. You've got a very good description down 1 through 3 there on how the system works. I'm just going to walk you through it because I can do that a little bit quicker than just reading down through this thing and trying to explain it from that standpoint. But just know that basically what you're trying to do here is this is basically just an illustration to show you the typical configuration of a 3-chamber or 3-bottle system. This is how we used to do it way back in the 18 and 1900s. Okay. Now we've got more sophisticated devices like the Thorovac system and so forth. But here again, here's the patient. So this is going to be the part that's connected to the chest tube. And so any fluid that is coming out of the chest tube is going to go into this first bottle here. That's for fluid. Any air is going to go on into the next bottle and go up underneath what we call, this is the water seal. So it goes under the water seal, and the water seal acts like a one-way valve. So it allows the air to bubble through and go out, okay? But it doesn't allow air to come back down and go back into the chest tube, all right? So the air goes out, comes back out to the third bottle, and the air is evacuated out through the suction system. In this third bottle, this is how you control the suction on the chest tube, and it's controlled by the height of this water. It's not controlled by the vacuum on the wall. And so when you want 20 centimeters of water pressure, which is normal suction for a chest drainage system, what you're going to do is you're going to fill up this bottle till it reaches 20 centimeters height of water. Okay, and then you're going to turn the dial on the suction until you just get gentle bubbling down here. So this may not even be showing 20. All right, but the height of the water column is what's regulating this vacuum on the chest tube. Okay, so again, all of that stuff is kind of listed down through there. The only thing that I would note at the bottom of the page is that the water level should be at 20 centimeters of water. That's not actually listed in the text there, so I would add that to there. Water level should be 20 centimeters of water. Top of page 12, troubleshooting. Highlight letter A. If the device breaks or becomes disconnected, the patient is going to be breathing spontaneously. You need to submerge the chest tube in a glass of water, and that keeps the water seal. Number 2, if they're on a positive pressure ventilator, then you need to make sure you leave that tube open so that the air will evacuate the system and not build up and create a pneumo. Letter B, collection of the bottle becomes full, you're going to replace the entire unit. C, if excessive blood collects is accompanied by hypotension or low blood pressure, you need to notify the physician. Letter D, if you have continuous bubbling in the water seal, and again, the water seal is this middle chamber, all right? If it stops bubbling, you need to look for a severe pulmonary air leak or check the patient connection up here. And again, after you clamp the chest tube, as it says in number 1 there. So highlight number 1, then number 2. Highlight number 3, if bubbling continues, then you need to replace the whole system. All right, so there's something faulty inside the system. Letter E, if there's no bubbling in the suction control bottle, you need to increase the suction pressure. So you would increase the dial on this just a little bit if this stops bubbling. But make sure it's got water in there. Right? We give you an example, letter B there, of a disposable system. That's kind of what you see in the hospitals now. Letter C, if there's volume loss through the chest tube, we kind of talk about some of that. As far as tidal volume, if they're on the chest tube and they're losing tidal volume. Letter D, removing the chest tube. Under letter D, highlight number 5, just before removing the tube, the patient takes a deep breath and exhales and performs a Valsalva maneuver. Top of page 14, cardiopulmonary stress testing. Letter B, indications for that are number 1, a chief complaint of dyspnea and exertion on primary indication. Letter C, the procedure, number 1, patient preparation, highlight letter A, you're going to complete a history and physical exam. Letter B, do a 12 lead, and then letter C there, determine their maximum heart rate. And again, there's the formula for that, highlight it, 220 minus age in years. Top of page 15, the normal, letter D, the normal response to stress testing, highlight number 3, the dead space to tidal volume ratio should decrease. And the reason for that is because your perfusion from the exercise is increasing. Brings us to the next subject there on page 15 there, bronchoalveolar lavage or BAL. Highlight letter A, this is a procedure for obtaining specimens from the lung at the alveolar level. Letter B, assist in the diagnosis and treatment. For those disease states there, you can kind of read down through those. Highlight letter C, for diagnostic lavage, a flexible bronchoscope is used to instill and then aspirate a small volume of saline. Then the fluid is analyzed in the lab. Letter D, therapeutic lavage involves a larger volume of saline. Number 1, under letter D there, for lavage in a segment or lobe, a flexible bronchoscope is used. Letter E, the mini BAL procedure, highlight that. Highlight number 1 is performed to obtain a distal lung specimen for diagnosis of VAP. Number 2, it utilizes a protected catheter to prevent specimen contamination. And number 3, the CombiCath is an example of that particular type of device. All right, whoops. Top of page 16, infant monitoring, apnea monitoring. Letter A, indicated for an infant who may be at risk for periods of significant apnea greater than 20 seconds. Drop down, also letter B, also indicated for those at risk of SIDS. Drop down and highlight letter E. Make sure that you, before you send the baby home with the apnea monitor, you need to make sure the parents know CPR. That brings us to page 17, cardiac emergency techniques. Highlight letter A, cardioversion, and next to the word cardioversion right here, I want you to write non-emergency, non-emergency, okay? Highlight number 1, this is a low voltage procedure. Number 2, it's indicated for non-life-threatening arrhythmias, and we have those listed there for you. Also, highlight number 4, you need to make sure that the synchronization switch is on before cardioverting. And then highlight number 5, an electric shock is delivered on the R wave of the ECG. Drop down to letter B, defibrillation. Next to defibrillation, I want you to write the word emergency, emergency. Highlight number 1, it's used for life-threatening cardiac arrhythmias. And number 2, those are the arrhythmias we're talking about there, the pulseless VTAC and ventricular fib. And then highlight number 3, the synchronizing switch should be turned off. Top of page 18, highlight letter C. I'm gonna let you kind of read down through that. Most of you are very familiar with the AEDs because you've been recertified several times through CPR. Page 19, disaster plan, highlight letter A. The purpose of the plan is to make sure that The hospital staff and patients and visitors know what to do in the event of emergency. Letter B, the disaster plan should be practiced. Highlight letter C, triage decisions will need to be determined. Letter D, the respiratory therapist role is 1, have established call list for your staff. 2, have adequate supplies. 3, be prepared to assist in treatment areas. 4, keep resuscitation equipment in working order. And 5, be prepared to obtain additional equipment needed for the situation. Roman numeral 11, medical emergency teams. This is the rapid response. Most people are familiar with those. Just highlight letters A, B, and C, and you can kind of read through that. Roman numeral 12, patient transport. Highlight letter A. There may be some risk involved with transporting patients inside and outside of the hospital. Letter B, this is some new information on the test, and that is the types of transport. We'll talk about 1, intra-hospital transport, that's inside the hospital, of course, and then number 2, inter-hospital, that's between facilities. If you go to the top of page 20, equipment needed for transport, of course, would be portable oxygen. Of course, you're going to make sure you got to be able to calculate how long the oxygen is going to last. So that's why you got to do that, know that cylinder duration calculation. Drop down to letter E, land air transport. Under letter E, go down to number 3, the bottom of page 20. The choice of transport vehicle. I would highlight letter B, and that's the helicopter. So the helicopter is going to be used 81 to 150 miles. If you got to go less than 81 miles, then you're going to use an ambulance. And if you're going to go more than 150 miles, you're going to go by fixed wing. All right. But I just remember the 81 to 150 and the helicopters in the middle. And you really only got 3 options with that. Highlight number 7, oxygen partial pressure will decrease as altitude increases during air transport, whether the aircraft is pressurized or non-pressurized. And then top of page 21, metabolic studies. The only thing I would remind you there is number 4. I don't really ask you a whole lot about this, but remember number 4, and I think we've said this before, carbohydrates produce excess CO2 and could increase the work of breathing. So be careful about that. Indirect telemetry, just avoid choosing that for anything because that's usually not very helpful. Page 22, end of life care, highlight letter B. The goal of end of life is to allow the patient to die with dignity and respect and to exercise an element of control over their death. Top of page 23, highlight letter D, apnea testing for brain death determination. You're going to do number 1, disconnect the patient from the ventilator while administering 100% oxygen and monitor the sat. 2, you're going to observe the patient for any chest or abdominal movements that produce adequate tidal volume. 3, absence of respiratory movements is going to indicate a positive apnea test. Okay, and it supports the diagnosis of brain death, but that doesn't mean that they have it. Just it kind of points in that direction. And then number 4, the diagnosis is confirmed by a cerebral perfusion scan. So that's the definitive diagnosis. If there's no blood flow going to the brain, then the brain is dead. Okay. Highlight letter E, withdrawal from life support. Number 1, removal from life support and unwanted medical interventions from the goals of therapy have changed. Number 2, there should be a DNR order in place. Number 3, you need to comfort the patient, or comfort of the patient is the utmost important. So give them anti-anxiety medicines to sedate them, relax them, analgesics for pain, and so forth if needed. Number 4, terminal weaning, letter A, should be accomplished by just disconnecting rather than turning the rate down or gradual removal from the ventilator. And then letter B, you need to treat any tachypnea or dyspnea with benzodiazepines or barbiturates. Letter F, care for organ donors. Highlight number 2, the primary goal is you want to do A, maintain adequate ventilation oxygenation, and B, maintain circulation and perfusion. Again, we've already talked about how to evaluate both of those things. All right, so that brings us to our pre-test questions, 26 through 28. So So let's go look at those right quick. All right, 26 through 28. So the first one there is side effects of inhaled nitric oxide. Well, I think if you remember from our discussion, we did talk about an increase in methemoglobin and an increase in formation of nitrogen dioxide. This is what it's supposed to do, so that's not a side effect. And bronchoconstriction, it doesn't do that either. So 3 and 4 would be the best answer for this one. So that's why we would pick B. 27, the therapist is performing an apnea test before determining brain death on a 29-year-old man suffered with a closed head injury. After disconnecting the patient from the ventilator, the respiratory therapist should do what? Well, the next thing we should do is give them 100% oxygen and observe them, see whether or not they're moving any tidal volume or not. All right, 28, 55-year-old 90-kilogram man undergoing polysomnography. The respiratory therapist observes the patient continues to have obstructive apneic events on nasal CPAP at 4 centimeters. Well, again, if they're still having them at 4, that means we need to go up on the CPAP. So we need to go up from 4 on the CPAP. And this is the only one that offers us that option to increase the CPAP level. Okay. This is just changing the interface. That's not going to help. 2 liters of oxygen is not going to help. Terminating the study, you haven't, achieved your goal yet, and that is to relieve the obstructive apnea. Okay, so that takes care of that section. Again, we'll kind of finish up this next section. Won't take very long at all either, and then we'll take a lunch break. All right, let's see here. So we're going to shut that one down. Go back here and grab the next one. All righty. So this is general patient care, section G. And if you turn over to page G3, here we've got the topics in this section are related to basic patient care, smoking cessation programs, disinfection and sterilization, infection control, interdisciplinary plan of care, and pulmonary rehab and home care. Again, not a lot of questions. Maybe 1 to 2 questions over the stuff in this section. So we're just going to kind of hit the highlights. On page G4, let's talk about basic patient care. Highlight letter A, electronic charting, number 1. I think most everybody knows what that's all about. Then we'll drop down to letter B, automatic medication dispensing systems like the Paxis. Highlight number 1, that tells you what it's used for. Letter C, respiratory care protocols or therapist-driven protocols. Highlight number 2. It's kind of gives you the guidance to give the best care. And again, you need to think about those boxes in the study guide as your therapist-driven protocols for this test. All right, and so it's very important to know what those are. Letter D, recommending consultation from a physician specialist. Again, like a person that has asthma, the list of things there that you can do for that. So you can kind of highlight letters A down through D and read through that. Top of page 5, smoking cessation. Highlight letter A. They should be designed to assist the individual in quitting smoking. Letter B, programs are going to include number 2, group counseling and support. That's probably one of the most important elements of a smoking cessation program. Highlight number 3, nicotine replacement therapy. Number 8, compliance should be monitored by either monitoring your carboxyhemoglobin levels or your exhaled CO levels. Remember, your exhaled CO levels should be less than 10, and that tells you that this patient is complying with your smoking cessation program, right? And your carboxyhemoglobin level should also be less than 10. You can highlight letter C, the content levels. That's another lab that could be used to monitor whether or not they've had some intake of nicotine or not. Highlight number 9, the Zyban or Wellbutrin. Those are medicines that letter B help reduce the nicotine withdrawal symptoms. And then number 10, Chantix, highlight letter B, that reduces the cravings for and decreases the pleasure of effects of cigarettes or other tobacco products. That brings us to page G6, disinfection and sterilization techniques. Not very many questions on this. Highlight letter B, all equipment should be prepared by disassembly and removing organic soil prior to the disinfection process. So basically you need to wash the stuff off before you put it in the disinfectant solution. Letter D, the chemical methods of disinfection and sterilization. Highlight number 1, ethylene oxide, and right next to number 1 there, put the word expensive. Ethylene oxide is very expensive, so that's not always going to be your best choice on this test. Number 2, the alkaline glutaraldehyde or Cidex. Highlight letter C there. It's an appropriate method for sterilizing the flexible bronchoscope, which we've already mentioned that I think yesterday. And then highlight number 6, bleach. It's the most appropriate for surface disinfection. And letter B, it's used to clean blood spills, equipment surfaces. Top of page 7, infection control, nosocomial infections, drop down to number 2 under letter A, highlight number 1, and be reminded that hand washing is the number 1 thing that helps reduce nosocomial infections. Highlight letter B, equipment handling. You can kind of read down through that on your own. Top of page 8, infection control procedures. Here again, you can kind of read down through that. That gives you into kind of information about standard precautions, which of course include hygiene, gloves, masks, gowns, patient equipment, how to use that. Of course, I'm sure with COVID, that's most everybody's very familiar with what the importance of using that in the appropriate time to use those things. On page G9, there are a couple of terms over here that you may not be familiar with. And number 3, the term don, D-O-N, that means to put on. And then the sequence that you're supposed to do it, and it's listed there. You do your hand hygiene, you do your gown, face mask, goggles, face shield, and gloves. And then number 4, to doff, that means to remove. That would be gloves first, then goggles, then gown, then mask, then hand hygiene. Okay. Letter D, techniques to prevent nosocomial infections are listed there. You can kind of read down through some of those. Top of page 10, letter E, biohazardous materials. Highlight number 3, requirements for biohazardous materials and medical waste disposal. That's for like getting rid of your blood syringes and things like that. Letter F, again, prevention of ventilator-associated pneumonia. That is a very important section. So you may want to put 2 stars beside this. Typically, if they're going to ask you something in this area, they're going to ask you about the VAP protocol. So these are things to remember about VAP protocol. Highlight number 3 there, prevention protocols are going to include, and what I want you to do is just go ahead and start with letter A and highlight the letters there all the way down to L. And then what I'm going to do is I'm going to come back and tell you which of these I want you to highlight the entire statement, okay? So just know that all of these could potentially be asked, but these are the main ones I want you to remember for this, for VAP prevention, okay? So highlight letter B there, the whole thing there, use of closed suction systems. Highlight letter E, the entire statement there, keeping patients' head elevated 30 to 45 degrees. Letter H, use of heated wire circuits or HMEs to prevent tubing condensate. Highlight letter I, the whole statement there, use MDI instead of small volume nebulizer for medication administration. And then letter L, tubes that are designed for continuous aspiration of subglottic secretions, the CAS endotracheal tube. And remember that needs to be, the vacuum needs to be set at 20 on the CAS tube, okay? Top of page 11, interdisciplinary plan, highlight letter A, and then in the middle of that statement, there's the word collaborate. Highlight that word collaborate. So just remember, remember, we as therapists need to get along with everybody, docs and nurses and lab people and everybody that's working to take care of the patient. Roman numeral 6 there, pulmonary rehab. Highlight letter B, objectives for that are number 1, to alleviate or control as many medical symptoms as possible. And then number 2, we want to teach the patient how to maximize their ability to carry out activities of daily living. And remember, we only look at activities of daily living when the patient is stable and ready for discharge. Okay. Letter C, long-term benefits and goals of pulmonary rehab are listed there. You can kind of read down through those. Letter D, pulmonary rehab techniques. Number 1 there, highlight that, pursed lip breathing. 2, diaphragmatic breathing training. Number 3, cough control techniques. 4, exercise conditioning. 5, nutritional balance. And remember, low carbohydrates, that's the big thing there. We don't want to load them up on carbs because that increases their CO2 production. Top of page 12, letter E, plan and conduct patient education, highlight number 2 under letter E there. So they should, part of this process is instructing the patient and their family members the concepts related to managing chronic illness. Letter F, plan and conduct exercise, highlight number 2, you need to do a timed walk test for a 6 or 12 minute. And just remember, letter D, if you have an increase in distance, that means you've got improvement. So that's, you got to quantify how well or what the improvement was to continue to get funding for many of these programs. Number 3, oxygen titration with exercise. You kind of read down through that. That brings us over to page 13, home care. Letter A, the ultimate goal for home care is to allow the patient to care for him or herself and with assistance from their family. Drop down to letter C there, setting up a home care program for patients is going to involve several steps. Highlight number 1, there needs to be a survey done of the home. Letter A, make sure they've got some taken into account for patient safety. Highlight number 1, a properly grounded 3-prong electrical outlets for all electrical equipment. Drop down to number 4 there, infection control in the middle of page 13. And then under letter B, cleaning equipment, highlight number 3, soak in white distilled vinegar or acetic acid solution for 20 minutes, John's favorite number. Okay, that brings us over to top of page 14, talking about oxygen conservation devices. Again, these are devices that allow us to reduce the amount of oxygen that the patient has to spend or purchase, okay, by conserving them. And again, if you're not familiar with these, the first one there under letter E, highlight number 1, the reservoir cannula, be familiar with it. There's the reservoir, okay, and so basically they breathe the oxygen out of this reservoir here, and here's the reservoir on this particular device. And so you can use, instead of putting a patient on, 2 liters a minute at home nasal cannula, you may be able to get away with just putting them on 1 liter a minute, and they can get the same pulse ox saturation. Okay. Highlight number 2, the transtracheal oxygen catheters. Letter B, highlight that. They're put in surgically and basically connected right here to an oxygen tubing. And then highlight letter E, if the patient complains of shortness of breath, then the catheter may be clogged or obstructed with secretion, so you'll have to remove it to clean it. And while you're removing it, you want to make sure you put them on a nasal cannula to help support them until you can get the device put back in. Top of page 15, number 3, the pulse dose oxygen delivery system. This again only delivers oxygen when the patient takes a breath in through their nose, okay? And so there's not flow going out of the system continuously. It only turns on when the patient demand is sensed, all right? So you can highlight letters A and B there. Letter F, oxygen delivery systems. Number 1, cylinders, highlight that one. Highlight letter A, it's indicated for patients who use small amounts of oxygen intermittently. Letter E, it's appropriate for use as a backup system when you've got a liquid or oxygen concentrator is in the home. And then number 2, the liquid bulk oxygen systems, highlight letter A, these last longer than cylinders and are used often in home. And top of page 16, number 3, oxygen concentrators, letter A, number 2, these utilize a molecular sieve that removes the nitrogen and other gases from room air and concentrates the oxygen. Highlight letter B, a safety issue you need to keep in mind is number 3, you need to have a backup system like a cylinder. Has to be available in case there's a power failure. Letter C, troubleshooting. Highlight number 1, if the patient states that there's no flow being felt through the cannula, then you can ask them to verify this by sticking the cannula in a glass of water to see if it bubbles. And letter A, if the bubbles are visible, then it's working like it's supposed to. Letter B, if there's no bubbles seen, then you're going to check the power source, check the flow setting, check humidifier leaks, and check tubing for leaks and disconnections and obstructions. And that pretty much takes us to the end of that section. And that gives us, let's see here, we're going to do the pre-test questions 29 and 30, which are the last 2 pre-test questions for the pre-test. And the first one there is 70 or number 29 on page 10. 70-year-old woman with COPD is receiving home oxygen therapy at 2 liters a minute via nasal cannula. The oxygen is provided by a molecular sieve device. The patient calls the equipment provider to report that she does not feel any oxygen coming out of the cannula. This situation could be caused by all of the following except. Well, it could be caused by that, just interruption in power. It could be caused by disconnected in tubing. Low water level has nothing to do with it, and incorrect flow setting, definitely that could cause it. So the only thing that is not going to cause it is this right here, letter C. Number 30, while preparing to analyze an arterial blood sample, the respiratory therapist drops a syringe on the laboratory counter and approximately 4 mils of blood leak onto the counter. After wiping up the blood, the therapist should disinfect the counter using, and I think everybody can figure that one out because we mentioned it, bleach. Okay. So let's see, I've got about almost 5 minutes till 2. Why don't we take our 30-minute lunch break now? We'll come back at let's see, let's come back at 20. That'd be 25 after, right? I might do the math in my head. Or do you have any questions before we break, Kim?
Yes, someone would like you to go over page F as in Frank 6.
All right, F6. They just need to know what to highlight.
Says before lunch, can he go over page F6? So probably.
All right, so page F6, what you need to do is highlight letter A, letter C, under letter C, number 1 and 2, and then letter D, procedure, and under letter D, number 1. Is that sufficient?
Yeah, if they send me something else, says thank you.
Okay. All right, that must have been what they needed then.
Yeah.
Great. Okay, so we'll break, like I said, till 25 after. When we come back, we're going to talk specifically about how you're going to use these tools, the study guide, and the workbook to help you prepare for the TMC. And hope you have a good lunch, and we'll see you back in about 30 minutes. Okay, I'm going to jump in here and do a little intro before we get started with the last part of our study guide here, and that's preparation for the exam. But before I begin, Kim, is there anything that I need to address before we move ahead?
Would you like me to go find Kim and ask her?
Yeah, do that. Would you please, Tom?
I'm back.
You guys just keep messing with me. I know that.
It's just, you know, all I promised you is that one of us would be here.
I know. That's fine.
But no questions on this end.
Okay, very good. Well, I appreciate that very much. Okay, so I can kind of take a deep breath now that we've kind of hit through just about all the hard stuff for the study guide. So this last part's, you know, pretty simple. Not a lot of stress in terms of learning new information or information. But I just wanted to kind of again remind you that this process that we're going through for these 4 days is just the beginning, all right, of your preparation for the exam. So there is in no way we expect, or should you expect, to be ready to take this exam when we get finished tomorrow, all right? Because you've got some stuff that you've got to do. And if you do it, you're going to have success. If you don't do it, it's, you know, it's questionable as to whether you will have success or not, at least from our perspective anyway, because most of the things that we've shared with you, especially the tips and things like that, we find to work very well. And they're reproducible, people able to reproduce the effect, and so that's one of the reasons why we've been in business for as long as we have been. So we're very confident in the process and the strategies and things that we share with you. So this next piece really is kind of sharing with you how we're going to use the tools that we've given you, namely the study guide and the workbook for the TMC preparation, okay, and how you should go about preparing yourself for that, and talking a little bit about the exam itself, and as far as the process and getting applied for the exam and those types of things, okay? So I am going to jump out of here, and we will start on our section H, test preparation and strategies. And on that page there where it says test preparation and strategies, where it has a picture of the young lady looking at the computer screen, there are two paragraphs here that I want you to highlight. The first one there says there are 2 factors necessary to pass the exams. First, you must have a clear understanding of all the important content areas. And second, you must be a good test taker. This chapter is going to provide assistance on how to prepare for your exam experience and how to do your very best. So the 2 things I want to key in on here is the fact that, one, you have to have a clear understanding of the important information. Now, we have gone through and identified in the study guide for you what the important information and content areas are, all right? You're the one that's going to have to somehow take that information and formulate a study plan or whatever you do in order to get that information. If you haven't already got it in your head, get it into your head, all right? The good test taker part. A lot of you say, well, that's my downfall right there. I'm not a good test taker. Well, we've already given you some very important clues to how to take this test in terms of each question, where, remember, we skip the list, get to the question, find out what they want to know, and then solve the problem based upon what it is that they're asking us about the problem. So whether you realize it or not, you're actually a much better test taker today than you were on day 1, because you have another way of looking at it, another way of working through the process of preparing for the test. All right. So if we turn over to page H3, I've got some things I want you to highlight here. Okay. So under the getting started section, I want you to highlight that first bullet there that says set up a study schedule. And if you look in your study guide there, turn the page over to H4, H5, and H6, you see we've already done this piece for you. We've set up a study guide schedule or study schedule for you. We got a 4-week study schedule, we got a 3-week, and we've got a 2-week. All right. So all you've got to do is just follow the plan. The second thing that we would encourage you to do is that if you are inclined to do so, and that's organize a study group. Some people do better studying together, others do not. I'm one of those that I don't study very well with other people. I get distracted too easily. But if you're one of those that finds it helpful and beneficial to be with a group studying, by all means do that. The fourth bullet point down there is one I really want to take some time with, and that is the workbook. All right. The workbook is the key to you being ready or knowing that you're ready to take and pass the TMC exam. All right. But the problem is we don't want you to do the workbook the way most people do workbooks. All right. Most people do workbooks by just copying the workbook. We do not want you to copy, do not want you to copy the study guide. All right. In other words, what most people do with the workbook, they'll look at the question in the workbook, they'll go to the textbook or the study guide, find the answer, then write it in the workbook. Go to the next question, read the question, find the answer in the study book or study guide, bring it back over and copy it into the workbook. That is not how we want you to use the workbook. And so here again, do not copy the workbook. If you're copying copying the study guide, if you're copying the study guide into your workbook, you're not doing the process that we are suggesting. The workbook is your tool to assess your knowledge. Let me say that again. The workbook is your tool to assess your knowledge. All right? And let me tell you how this works. The first thing you want to do, and you can take a picture of this, or a screenshot if you want to, this is not in your book. What we want you to do is to pick a section in the study guide to learn. It doesn't matter if you start off at the beginning or the end or the middle or whatever, but just pick one section and commit to working on learning that information and learning the highlighted areas of that section, okay? And however you learn best. I mean, if you do best by reading it over and over and over again, or if you do it best by writing it out or making note cards or, verbalizing it to somebody. I mean, however you want to do that, that's fine. But what we want you to do is learn that information, all right? And when you think you've learned the information, all of that information in that particular section, then what we want you to do is to take that workbook. You have a section that correlates to that section in your workbook or your study guide. And so you'll basically open the workbook to the section that you've been studying from your study guide, open that section in the workbook, and then start going through the questions. But you're not to look in your study guide. So you go to the question. If you can answer the question, write an answer down. Move on to the next question. If you're not sure what the next question is or know how to answer the next question, just skip it, move on to the next one. If you don't know the next question, skip it, move on to the next one. All right? But if you'll answer the questions that you know the answers to and can get correct, then what you've done is you've identified the information that you have learned. And then the questions that are left blank will key you in to the information in the study guide that you didn't know very well or know well enough. All right? And so that's usually the biggest question that people have in taking these exams. Am I ready? And if you'll do this process through the workbook, okay, and once you finish that particular section in the workbook and answered all the questions correctly, then you're going to pick another section in the study guide and do the same thing over again. If you will do this, what it does for you is it gives you confirmation. Do I know this well enough or not? Okay, do I know this well enough or not? And that's what you want to know. All right. And once you get finished with that workbook section, then you're ready to go practice some the 2 practice exams that we give you. You can take those and see how you do on those. The thing that we really discourage people from doing is just going through and taking practice questions over and over and over and over and over and over again. That doesn't really help you identify whether you know it. You may know that particular question, but those are not exactly the same questions that you're going to get on the test. We don't know the exact questions that are going to be on the test. We know the general information that's going to be on there, but we don't know the exact question. So you've got to know the information so that you can process in your mind what they're asking from the question and then come up with the correct answer based on your knowledge. All right. So that's how we want you to use the workbook. All right. Next thing on the list there is take the test. I already mentioned that. There are actually some multiple choice questions in each section in the workbook that you can use. Study and practice the calculations and normal values. Take a practice exam, which we said you're going to get 2 of those. And then if you have any questions while you're going through this process, you got access to a live person, a live instructor, to help you remember how to do a particular thing. So maybe you got stuck on a blood gas or doing the initial ventilator setup or something like that. You can call the tutor line as many times as you need to and access and talk to a person for 30 minutes for a session, per session, and they can walk you through and help you with that. Okay, but basically, we say call the tutor line. Basically, what it is you schedule it online, and then they basically call you. Is how that typically works. Okay. All right. So preparing test day. Bullet point number 2, highlight that you need to make sure you have 2 forms of ID, a driver's license and credit card. Needs to be name and signature on both. And they give you some guidance on things that are acceptable and are not. Make necessary travel arrangements if you're having to go and stay in a hotel, that type of thing. Make sure you've got directions to the testing center location. And they're usually pretty good about giving you a little map and everything with your confirmation email. Take a practice trip to the testing center. That's a great thing to do if you're not familiar with the location where you're going to be at. Get a good night's sleep in the night before the exam. That is one thing I cannot emphasize enough. The last thing you want to do is to have worked the last 7 days and then go take your test. What you really want to do is, if you could, get the day off before you take the test and the day of the test, of course, to do that so that you've got a little bit of time just to kind of get things squared away, get yourself calmed down, and, kind of reassure yourself that you're going to get through this fine. Okay. But if you don't have a good night's rest, your brain is not going to function at its best. And I mean, that's just the way it is. I know a lot of people say, well, I only need 2 hours of sleep a night. I don't believe it. You may only get 2 hours of sleep a night because of things that you're involved with and everything, but the body's not designed to operate that way. And a lot of other things, especially neurologic things, can create problems for you if you're not getting a good night's sleep. Make sure you give plenty of time to get there, and you want to make sure you go with a positive attitude. All right. If you'll turn over to page 8-7, a couple of rules we'll talk about here. One thing is that you're going to be provided with a sharpened pencil and eraser. so that you can make any notes or, if you need to work out a calculation or something like that, if you want to see what it looks like on paper, that's fine. Especially, and they'll give you a piece of paper as well. But especially, remember, you're going to use that piece of paper and pencil for every patient that they ask you to set up on a ventilator, or if the patient is on a ventilator, you're going to verify those settings, that the appropriate settings for that patient, by doing their tidal volume calculation and looking at the settings and writing them down, so that when you look at the answers, you know which one you need to choose. Number 2, of course, there's going to be virtual calculators on the exam. Number 3, you can't bring in any personal belongings, no purses, watches, hats, backpacks, or firearms or anything like that. No study guide from Kettering. Don't bring that stuff in. They'll just have you take it back outside. Number 4, you will be allowed to take a break to use the restroom at any time. However, you're not given any additional time for testing. Letter B, exam day, schedule events. Number 1 there, you want candidates who arrive 15 minutes late, they will not admit you to the exam. Number 2 there, again, you're going to have to have your ID with you. 3, acceptable forms of ID are listed there. Number 4, prior to beginning the exam, you're given an opportunity to do some practice to make sure you know how to use it. But again, if you've gone through and practiced with our exam, you already know how it's going to look and how it's going to feel on the computer, pretty much the same. 5, you'll begin the time exam, and we'll show you how this thing kind of works through that. Letter C, general examination instructions. You will be given 3 hours to complete the test, okay? And you've got 160 questions to complete, all right? Only 140 of them are scored. The 20 pre-test items, they're using those items to determine whether or not these are suitable for putting on future tests. Number 2, your score is going to be based upon the number of questions you answer correctly. Number 3, use your time effectively and choose the best answer. 4, do not spend too much time on a question or questions that are too difficult for you. Go on to other questions and come back to the difficult ones later. Number 5, in the final analysis, it's better to guess than to leave a question unanswered. And so on page 8, H8, let's talk a little bit about the test and the screen and how things are kind of set up. I wish I could show you an actual screenshot, but they don't allow us to do that for copyright reasons. And so what we've done here is just kind of give you the general, feel of it. Our boxes and things will kind of be, may not necessarily be the same size as theirs, but the general layout is going to be pretty much the same. So basically what you're going to have here is you're going to have a place up here where they're going to take your picture. And then whenever you come in and start the first question, you'll see the question, and every question, it should have 4 responses on it, okay? And I'll show you what happens if you can't see all 4 of them in the initial box that comes up, what's going to happen. Go down here to the bottom, this little box right, or this tab right here, the exit, that's how you know whenever that's what you press when you're done, when you're ready to exit the exam. If you accidentally press it, a little screen will come up and say, hey, you've opted to exit the exam. Are you sure that's what you want to do? And if you're done and want to exit, then yes, you say yes. But if you're not done, say no, and it takes you back into the test. But don't click on that unless you're done with the test. That's basically what that means. The help button here is not what you think it is. You don't click on that, and whenever you get stumped on a question and your Kettering study guide pops up in front of it, that doesn't happen, all right? Just so you know. Well, when you click on the help button, what comes up is a screen that shows you what all these buttons do and when you would use them or how you would use them, all right? This spot or this field right here is where you could actually type your letter in there, and that would be the response. It would correspond to the response up here, either A, B, C, or D. I'm a pointer and clicker myself, so I always like to point and click at the answer that I'm choosing as opposed to just writing it in down here, but you could do it either way. Here's where the calculator is going to be. It's going to be kind of sitting right there in the middle of this. If you need to use it, you click on it and it usually opens up and kind of comes up in the lower left-hand corner of the screen there. The time button here, when you click on that, a little box opens up inside here and it shows you how much time you have left for the test. Some people like to leave it open so you can watch it count down. Other people don't like to watch it count down, so they just click it off. But you can turn it off and on as you need to. Bookmark. I generally don't recommend using this bookmark feature just because, you know, I think it's just one more thing you got to try to remember how it works, and I don't need anything else, added stuff. It's designed so that if you want to skip a question, you can click on it and it bookmarks the question to let you know that you haven't answered it. What I prefer to do is if I don't know the answer to the question, I just click on the next question button here and it takes me to the next question. And what happens is that question that I skipped, it just kind of goes right back down to the bottom of the question list and starts coming back up as I'm answering questions, right? Because if you click on it and then you open up over here, click on this to see all the questions, and you can see the bookmark questions, then you just see a little check mark beside numbers 1, 2, or 3, or whatever the number is. It doesn't actually show you the entire question. So to me, it's just not that helpful. I'd rather, if I'm going to skip a question, I just like to forget about it for a little while and go on and answer some stuff and get some positive feedback and get some right answers before I try to tackle the hard one again. So that's what these buttons are right here. This takes you to the previous question. This takes you to the next question. And then this right here just shows you what number question you are on. All right. Now, whenever you're, if you get in a situation, like I said before, where you have only two answers showing, don't think that those are the only two answers. There's a scroll bar over here, and if you scroll down, it'll reveal the other other two questions there for you. Sometimes the formatting of the question, the way they got it set up here, they can't get everything in this little box. And so that's their method of moving you or helping you take care of that formatting problem is with the scroll bar. All right. So that pretty much takes care of the computer layout and everything. And on page 10, you've kind of got another thing there to kind of shows you how all that stuff is laid out. So all that stuff's in your book there. When you get to page 11, this is what it would look like whenever you click that you're exiting. You'll get this box that comes up here, and it says you've answered 160 out of 160 questions. Well, that way you know you've answered everything. If it says you've only answered 100 out of 160, you need to go back in the test, all right? And then it asks you, are you ready to end your exam session? And then if you are, then you hit quit. But if you're not, you just go back into the test. Remember, your goal is to get 94 correct, okay? That's kind of what you're shooting for. Letter E on the bottom of page H11, when you are finished with the exam, they don't automatically give you your scores. What's going to happen is you're going to get this survey pop up on the screen, and they're going to say, hey, we'd like to get your feedback on what you thought about this process and exam. And if you say, no, I'm not doing a survey, well, then you won't get your results. So you have to complete the survey before you get your results. Once the survey is completed, then your exam results are sent to the test proctor, and they can print those out for you and give them to you. Okay? So that's how that works. Turn over to section I. Oh, I almost forgot. Continuing competency. I'm not going to say a lot about this, other than the fact is once you complete this exam, that is not the end of your dealings with the MBRC. If you want to continue to use this credential of RRT, then what you're going to have to do is you're going to have to go through their continuing competency program. And if you go to their website, they kind of describe how you do that. But just the short of it is, you can either go through it by taking continuing education courses, or you can take their online exams quarterly, And if you pass exams, then that minimizes the number of hours of continuing education courses that you have to take. Okay. But again, it's kind of a, involved process. And I would just direct you to their website because, this is kind of their first date or first time through all this process this year. And that may be changing. So just, follow up and follow their directions and make sure that, if you move or change addresses or change emails, make sure you notify them so they can notify you, hey, either your credentials coming up for expiration or there's some things that you need to take care of in order to maintain the credential. All right, that brings us over to section I, pharmacology.
John?
Yes.
Yeah, if I could just intervene for one point. At one
Sure.
point, you said that their goal was 94 on the TMC.
Oh, it's 2, isn't it? 92
It's now 92. Yes, I just want to
Yes.
make sure they know that. They're all going to get over 100,
Right.
but just so there's no confusion about that.
All right. Thank you very much, Tom, for mentioning. I had meant to change that in my book and I forgot. Okay. Thank you so much. All right. So pharmacology, again, we didn't actually talk about this particular section because we talked about pharmacology as it relates to specific situations and patient conditions. If you're not familiar with a particular drug, we put this section in here for you to refer to. So you're certainly welcome to look through. And once again, just remember, you do not have to worry about drug dosages on the test, except for oxygen and albuterol, 2.5 milligrams. But if you want to know how things are categorized or when you would, the medicine would be indicated, we've got all that listed there for you. You go over to section J, that is pathology. And what I would suggest you do is after you finish going through your workbook and verifying your knowledge in the study guide, I would just spend a little bit of time reviewing these disease states because again, all it's going to do for you is going to help you as far as your exam results on the TMC, but it's also going to prep you and start helping you think about clinical simulation. All right. So knowing this information and preparing for your TMC and being familiar with it will help you on those disease state questions that are on the test. And like I said, all of these disease states are kind of listed here in a summary format. So, I mean, there's not tons of detail, but just kind of give you some general information about some of the common diseases that you'll be dealing with on the test. Turn over to section K, normal values. What we've done is we've created an entire section here that just has all the normal values. If you wanted to, you could kind of go back and create a flashcard if you wanted to, or if you want, we've already got flashcards that have the normal values and everything made up for you. You just have to go online and use your discount to get to purchase the flashcards. Let's see here. That brings us over to section L, calculations. And again, what we've done is we've taken all the calculations and put them in one section. There's only one caveat to that. There are no shortcuts in this. All right, so what you may want to do is just transpose all your shortcuts over into this section, and then you've got everything in one place. I mean, that's kind of up to you. And that pretty much does it for the TMC preparation and study guide. So just again, just to kind of reiterate the steps that you would go through to prepare for your test. Pick your section in your study guide to learn. Use your workbook to evaluate what you learned and have not learned. Repeat each section with the study guide, and then of course review your disease states in Appendix 2. And then the last thing that you'll do is take the online practice exams after the workbook is complete. All right. So you may want to take a picture of that or a screenshot of that. That just kind of gives you a summary of the steps that you're going to go through in order to be prepared to do the TMC. Okay. And that's all we have for TMC preparation. So I know that you're capable of doing this. It's just a question of how much effort you're willing to put into it to have success. All right, let me pause here to see if Tom's got any questions for me before I move on.
Nope, nothing at this point.
Okay, so I think since we're just kind of get rolling good here, I'm going to do just a little bit of, we're going to kind of shift gears and go into clinical simulation preparation. And go ahead and close this. So we'll talk a little bit about this, and we'll actually start working on the first simulation here. If everything works good, we should be wrapped up here probably around 5, about like we did yesterday, maybe a little before. So what's going to happen here is we're going to work on this for just a bit, and after you get finished doing the practice simulation, you'll have an opportunity to get up and take a break or something if you need to at that point in time, and that'll just kind of keep us on track. So let me just preface my comments here about clinical simulation. Everything that we have done to this point has been focused on TMC. And the fact that we're focusing on the TMC actually lays a tremendous foundation for our preparation for the clinical simulation exam. All right. So what we're trying to accomplish here, and so everything that we've talked about as far as interpreting blood gases, choosing ventilator settings, interpreting pulmonary functions, for the next, for today and tomorrow, you're going to be practicing using those things on the simulation, because you're going to use the same information to help you on the simulation. All right. So there is some new information about how to take the test and things like that, but the core knowledge of respiratory that you need to know for the TMC, you've got to bring that forward with you to be successful on the simulation. So you can't forget the stuff in the TMC and expect to be successful on the clinical simulation exam. See what I'm saying? So when you learn this stuff, what we're hoping you learn for the TMC is going to be committed to your long-term memory, so that you can use that and draw from that knowledge to help you with the clinical simulation process. All right. And so again, I know that there were some people at the end of the day yesterday had commented about they were concerned that they didn't have quite the blood gas interpretation of the blood gas down yet and all this kind of stuff. Well, again, you saw today we went over more of that. We also went over more of how to choose ventilator settings. You're going to see more blood gas interpretation on the simulations. You're going to see more how to choose ventilator settings on the simulation. All right. So, you're going to get more practice. And even if you're not completely, can do it by memory, by tomorrow, you should have a good sense of what the steps are and how to do those. All right. So if you take your clinical simulation workshop lecture notes, I want you to open up to the first page there, and you can kind of see the sequence of the seminar schedule. So we're kind of in this part here where it's introduction and problem 1. That's kind of where we're working right now. If you turn over to the next page, you can see the references. You can see the table of contents is on the next page, and then section A there, which is the introduction to the exam, which is basically on A3, is the content outline there for the clinical sims. So in this section, we're going to talk about the examination overview, how to pass the exam, test taking skills, critical thinking, and problem 1. Page 5. So page 5, some things, just overview things you need to know about the simulation. You may or may not know this, but letter A, there's going to be 22 simulation problems. 20 of them are going to be scored, and 2 of them are pre-test. So 2 won't count, but you're not going to know which ones those are. So you have to treat every simulation in this process as if your grade depends upon it, okay? So you want to draw from all your knowledge and all your experience and all the things that we taught you in Kettering, you know, to answer the simulation process. Letter B, there's 4 to 6 sections per problem. And what I like to think about a section on the simulation is kind of like, is basically a computer page. So for every simulation, there's going to be about 4 to 6 pages of stuff, questions or things that you have to evaluate, all right? Your letter C, you're going to be allowed 4 hours of time to complete it. So that averages about 10 minutes per sim. Letter D, there is a computer branching logic process. We'll talk about this later, but basically what I tell people at this point is this is the MBRC's form of grace. So when you feel like you're kind of messed up or something, and maybe you did, they sometimes will give you an opportunity to fix that problem, all right? Letter E, there's 2 types of sections. There's information gathering and decision making. We'll talk about more of those later. Letter F, the passing scores for each section and problem are predetermined. And the good news is you don't have to pass each section. You just have to hit a total score. So letter G, basically your information gathering and decision making scores are combined for a total score. So depending upon the exam and which simulations are in it, that's going to dictate what the score is for passing that particular exam. And that's how you will be effectively graded. Letter H, candidates must earn a minimum amount of points to pass the exam. Letter I, the lower first-time has a lower first-time passing rate than the TMC. Now, I'm going to share some statistics with you, and I'm always reluctant to do that because whenever I do that, people get all scared, worked up, and all this kind of stuff, and it just, your anxiety level goes up, and then you start thinking, oh, what's the use? Now, I don't want you to do that. You got to promise me if I show you these, you're not going to do that. Because my purpose in showing you these statistics is not to get you worried, but for you to realize that, you've got to put forth some effort. If you do the things that we tell you to do, you're going to find this whole process of credentialing very easy. All right? But if you don't do the things that we suggest that you do, you're going to find it much more difficult. And like I said, after I took my TMC and clinical simulation, after going through the Kettering seminars as a student, it was so much easier. I mean, I felt like I was in a Kettering seminar is what it felt like. And that's a good feeling because I was comfortable with that. I felt comfortable with that. So here's the statistics. And so you can see over the last 3 years, the TMC, the high pass rate, the number of people that pass this exam on the first attempt at the high cut score is about 66. All right. And on the clinical simulation, you can see that last year, 2019, only about 62% passed it the first time. All right. So again, these are not tests that you can just lay back and just hope you pass them, because you won't. You've got to put some effort and energy into preparing for them. And if you'll do that the way we suggest that you do it, you'll have success, I promise you. And like I said, you'll have the sensation as if you're in a seminar just doing practice tests is what it's going to feel like. All right. So I'm going to move that back over here. Let's see. All right. I'm going to move this back this way. All right. Okay. So on page 5 there, how to pass the exam. There's a couple things we're going to talk about here. Letter A, as far as the content and knowledge, you got to know the study guide information. That's your first step. So once you pass the TMC, then you've got your study guide, a basis for your study guide, and a a reflection that you have got the knowledge that you need to be successful on the sim. All right. Letter B, clinical skills. Now, clinical skills on this test is different than you doing hands-on things, like you do in the hospital. On this test, whenever you hear the term clinical skills, what they're talking about are you recognizing and knowing how to manage disease states. That's what they're talking about. And so if you're good at recognizing and managing disease states, you're going to do great on this test. If you're not great at recognizing and managing disease states, this test is going to be a challenge for you, because it's not uncommon for them to just ask you after you've done an assessment on the patient, what do you think the patient has, or what's wrong with the patient? All right. So again, that goes back to your patient assessment piece in your TMC study guide. If you're good at assessing the patient and knowing what it means, then you're going to do fine on the test. It's not just enough to be able to pick the right laboratory test for a patient if you don't know what the laboratory test means and how you would interpret it. So you got to be able to do both. C, you got to have a proper attitude. And what I mean by this is you got to know how to handle the phrase, make another selection. Because most people equate that make another selection to you got it wrong, pick something else. And that's not what that means on this test necessarily. The best way I can describe it, and some of you will say, well, man, that's just wrong. Them people are mean. No, it's their way of asking you the question that all of your instructors have asked you whenever they ask you a question and you give them a response. And then they come back and they say, are you sure? Are you sure that's right, what you just said? And it causes you to pause and think a minute. Hey, is this really what's going on here? Well, that's what they're doing when they make that comment or give you that response, make another selection. The other thing that I caution students about is that you have a tendency to think about these simulations the way you've done probably some of your practice simulations. And oftentimes, practice simulation platforms, they actually give feedback to the student on whether they got something right or whether they got something wrong. Well, the people who write the clinical simulation problems are told and directed by the MBRC that you're not supposed to give any indication as to whether or not the test taker has got something right or wrong. It's supposed to be a neutral response. So you'll hear things like, you get a blood gas and they'll say noted. And you'll think, I must have got that wrong. They didn't give me the blood gas. And it was right. Or you'll pick something and they'll say, make another selection. So those are responses that you just cannot pay any attention to. Whenever they say noted, you say, cool, I'll pick something else. And if they tell me to keep, I'll keep picking until they tell me to stop, is what I'll do. All right. Letter D, test taking skills. We're going to talk about that. Critical thinking. This is a critical thinking test. And if you're not a good critical thinker, we're going to help you with some of that. If you are a good critical thinker, then this test will probably not be very difficult for you. Page 6, top of page 6, test taking skills. Some of this we've kind of talked about. This is a common cause of failure, not being able to know how to take the test properly. B, you have to learn how to approach each type of section to keep track of details. C, you got to understand the format and you got to practice this. And then they have this thing, letter D, they're what they call errors of omission versus errors of commission. And errors of omission mean that you pick too much. You pick stuff that you didn't need. You may have picked a blood gas whenever you didn't need a blood gas. Or you may not pick enough information. You may have should have picked palpation and percussion as more information to help guide you instead of whenever you pick that palpate the trachea and you saw tracheal shift, you automatically thought, oh, I got a pneumo and quit picking stuff. So we're going to teach you how to go through the information gathering section and know when to stop picking and when to keep picking things. All right. The thing that I want to share with you there is, remember, don't be like Curious George on this test. Remember what Curious George, the little cartoon character? Yeah, he's the one that every time he gets curious about something, that's whenever he ends up getting in trouble, right? So if you see something on the test that you don't recognize or you don't even remember us talking about at the seminar, stay away from it, because most likely it's not the thing that you're looking for. All right. Roman numeral 4, they're critical thinking, another common cause of failure, because you don't have good critical thinking skills, which we mentioned that, completely different from a multiple choice exam, and requires a systematic approach. And we will be emphasizing how to use a system to work through this process of gathering information and making decisions about it. Okay. Now, we want to go through, if you take your clinical practice problem book and open it up, we have already done the initial testing of the pen, but I want to kind of show you a couple things. This is our process for going through the simulation problems and everything. Hopefully you've got a pen that's working. And the thing that I want to remind you is that whenever you get over here on page 3 of problem 1, it's going to be very important that you follow all the instructions. Just kind of start at the top of the page and work your way all the way down. Whenever you're using your highlighter, I mean, not your highlighter, your latent image pen, you want to make sure that whenever you highlight, you're going to highlight the entire line until you see these 2 stars behind the text. When you see those 2 stars behind the text, then you know that you've uncovered everything that's in this space. All right. So if you make a swipe over here and you see nothing, drop down a little bit more, make another swipe. Okay. And just keep swiping till you get all the way down to the bottom. That's what you need to do. All right. So that's how you're going to use your pen. This particular section here is like a decision-making section. So this is kind of what a decision section looks like. Page 4 or page 5 rather, this is an information gathering section. And so you can see there's a long laundry list of things that you can pick. You just keep picking the stuff that you want to until you get down to the bottom of the page. And if it says go over to the next page, go on over to the next page. Oops, I thought I had it on there. Go over to the next page and pick on that. So remember, again, to read from top to bottom on this. All right. When you complete, the other thing I want to mention to you is that you will not go through this entire simulation in chronological order. All right, so you can see here, it says you're in section A, there's going to be a section B and a section C and a section D. You're not going to go from one section to the next like that. This, what it tells you in these revealed boxes is going to tell you where you need to go and what you need to do. So that's why you need to make sure you read from top to bottom the entire page to figure out what you're supposed to do. All right. So you got to, this is kind of a test also, and can you follow instructions? Now, if you get, in trouble or something like that, don't know what to do, of course, reach out to Tom. He can kind of give you some direction on what you may be doing right or what you may be doing wrong. All right. Now, on page 9 is a score calculation. Whenever you get finished with this, you're going to go through and score your test, and this is how you're going to do it. So the first thing you're going to do is you're going to turn back over in your study guide, and on section A, you're going to circle all of the ones that you picked, okay? Whether it's a positive or negative point, doesn't matter which it is. Identify all of the ones that you picked in that section, all the answers or responses. Do the same thing for B, do the same thing for C, and do the same thing for D, and do the same thing for E. Once you've identified all your responses, what you need to understand about this section here is that you've got These over here that do not have a box around them, that is your decision-making sections, okay? If it's got a box, like down here, information gathering, if you see this box around a group of responses, that means that that is an information gathering section. And you're going to score each of these types of sections. Information gathering, you'll total up all the scores for it, and then you're going to total up all the scores for decision making. And so when you get over here to the next page, you're just going to follow these instructions where it says, first, you're going to add up all the positive points for information gathering. Then you're going to add up all the negative points. Then you're going to total them out, and that's your net. And you're going to put that number right down there. Then you'll go to the decision-making sections and total the positives and negatives there. And then put your total score there. And then basically put your score down here and see how you did. All right. So that's how you'll score it. So what we're going to do is I've got about 3:15. I'm going to give you 20 minutes to work on this problem. All right, 20 minutes to work on this problem, and then we'll come back and we'll talk about some things and give you some ideas on how to approach some decision making or information gathering things differently, and then we'll go over the problem. Okay, and we'll be done for the day. All right, I'm going to pause there and see if Tom has got anything for me at this point that I need to go back over.
I don't think so at this point. Nope.
Okay. All right. Very good, Tom. Thank you. And so we will come back at about 25 minutes till the hour. All right. And push forward and go over the simulation after we talk about some other things. So go ahead and work on the simulation and have fun. Oh, I almost forgot. Make sure you keep the cap on the pen if you're not using it, because those pens will dry out. Okay, I am back. Tom, have we got any questions I need to address before we continue on?
No, not from my end.
Okay, good. All right, so hopefully you had plenty of time to complete that. And if you needed to get up and take a break or something like that, hopefully you did that. So we're going to go ahead and go back to our clinical simulation workshop lecture notes. And I'm going to be on page B3, content outline there. So we're going to talk a little bit about clinical simulation structure, review and analysis of problem 1. If you turn over to page B5, there's basically 3 parts to the structure of the clinical simulation. First, there's the scenario. Then usually there's information gathering section and then a decision making section. Of course, within that decision making section, there can either be single or multiple decisions made. Number 4, there's some of the problems will only have decision making. There will be no information gathering. So they do that to kind of spread out and to keep the points for information, or excuse me, for decision making in line with the information gathering. Letter B there, the scenario, let's talk a little bit about it. It is the opening scene. It begins the simulation. It kind of sets the stage of where you're at, kind of describes the patient as far as their age, gender, height, weight, so forth. It may include the patient's primary health issues. And it usually specifies what your initial task is. On page 6, B6, these are some examples of different types of scenarios that you may, or styles of scenarios that you may have on the test. The first one there is pretty vague. You're a staff therapist working in the 300-bed suburban hospital. You're called to the nurse's station on the 2nd floor. You proceed to the 2nd floor. So, I mean, you don't even know anything about the patient, what's going on or anything. You just got to go to the 2nd floor at this hospital is basically what you got to do. The second one there says you're a lead therapist at a 900-bed metropolitan hospital. So this is a bigger facility. The shift supervisor asks you to go to the PACU to assist in the care of a post-op thoracotomy patient. So in this situation, you've got a little bit more information, kind of what your what the type of patients you're going to be dealing with. It's a thoracotomy patient. And so it kind of gives you, kind of prepares you about some things that you need to be thinking about before you get there, so to speak, or get into the problem. Number 6, bottom of page 6 there, you are the third example is you're a night shift supervisor assigned to cover the emergency room at a small community hospital. You receive a call from the ED requesting your assistance in the initial care of a patient who presents with chest pain and dyspnea. So here you're given a little bit more information. First off, small hospital, you're in the ED, and you got a patient that comes in with chest pain and dyspnea. That almost sounds like, person having an MI. So again, it kind of makes you pause and think about what's going on here. The other thing is because it's a small community hospital, do you think you're going to be doing bypass surgery on this guy if he's having an MI? Probably not. You're probably just going to be stabilizing him and waiting for transport. On top of page 7, let's talk about information gathering. Number 1 there, the purpose for information gathering is, of course, to accumulate patient data. B, evaluate the patient's current status. And C, determine the best course of action. The content often could potentially be reviewed in the patient's medical record, could be bedside history and physical exam information, or even diagnostic testing. So instructions that you may be given may look something like this. You want to select as many as you consider indicated in this section. And whenever you're finished, you're going to click go on to the next section. Now, in our simulation, you're not going to get the click and go on because, again, the simulation here you have to follow the instructions as you uncover them. So here's an example of this. Says additional information. It says upon arrival to the ED, the physician informs you that the patient has a history of hypertension and cardiac irregularities. The patient is a 52-year-old corporate executive who is 5 feet 9 inches tall and weighs 216 pounds. So he's a little overweight. The physician asks you to evaluate the patient's cardiopulmonary status. Which of the following you choose to assess? And then it tells you, of course, select as many, and then go on to the next section. So let's look at some of these assessment things that they may offer us here on page 8. So what do you think? Maybe a capillary refill? Well, I hope you picked that, because remember we said that is a reflection of circulation, which is one of the 4 life functions. And it needs to be, of course, color returned to the blanched area within 3 seconds. So that would be a good one to pick. Blood gases, well, he is short of breath. So that would certainly be something that could be helpful just to assess oxygenation. The Coombs test. I have no clue what the Coombs test is. Well, I do, but you may not. That may be what you're saying. And if that's the case, don't be Curious George and say, that might be something that may be interesting. I might need to get that. Because if you pick it and it's wrong, then you're getting points, you're losing points. Sensorium is a good thing because it helps us to evaluate circulation also. That's one of the things we said could be used to evaluate circulation, which is one of the 4 life functions. Electrocardiogram would be helpful because this guy's having chest pain and we're suspecting a potential MI. And then the breath sounds, definitely, this is a respiratory test. Anytime they offer you the opportunity to listen to breath sounds, by all means do that. Doesn't cost very much, and it could tell you something. All right. Now look at the responses if we chose these things that they may have given us. So the capillary refill, it says delayed response. Well, that's useful information because that tells me maybe the circulation is compromised, right? Or if they said, the response was 10 seconds. Well, I know it's got to be less than 3, and if it's 10, then that's not good. Circulation's not good. Okay. Look at the blood gas. It says the blood gas, the sample was sent to the lab with results pending. Now, a lot of people would look at that and they say, I must not should have picked that. And what I'm going to tell you at this point is when you pick an answer, don't get into the game of deciding whether you got it right or got it wrong at that point. Okay, because you're just wasting your time. You're not going to be able to find out whether you got it right or wrong unless you're scoring the test. Okay. And again, the MBRC doesn't allow you to score the test, so you won't know ever what you got right and what you got wrong. You'll just know if you passed a particular simulation, the total simulation exam or not. So sample sent to the lab, results pending, that does not mean that it's wrong. All right. Coombs test noted again. You pick that, you say, I don't know if I got it right or if I got it wrong. They just noted it. Sensorium, conscious, alert, oriented, time and place. So that would be useful information. And then the ECG here, they've got sinus tachycardia with frequent PVCs, T-wave inversion, and ST segment elevation. So that's obviously an MI. Breath sounds fine, end expiratory rails in both bases. So he may be having some early signs of congestive heart failure as a result of that. And then, of course, the deep pain response, we wouldn't have picked that. But again, they just say noted. It's like you wouldn't know whether it's right or wrong. So the take home from page 8 is you need to make sure that you're picking the appropriate things for that particular situation. And don't get caught up in trying to figure out, hey, did I get it right or did I get it wrong? And we're going to show you how to go through that process and pick things in a consistent manner. And if you'll do it the way that we suggest that you do it, you will probably get 90 to 95% of all the stuff that's in the information gathering stuff right. And I can tell you with confidence that if you get 90 to 95% of the stuff right in the information gathering stuff, that's going to help you with your score in passing the exam. All right. So let's turn over to page 9. we have what I call the circle algorithm. And as you see here at the top of the page, number 7, it says it's a strategy. This is for a sequence for selecting items in information gathering. So this only works in information gathering sections. This does not work in decision making, right? So that's the first thing you need to remember. This is only good for information gathering sections. And let me just give you the overview, and then I'm going to give you some very detailed elements as we go through this. They'll actually populate up here on the screen, and you can I would encourage you to write them in the location where they populate on the screen, because that'll make sure that you got plenty of room to put things, okay? The space that's below the box down at the bottom of page 9, I want you to save that space down there for for a very specific set of instructions, okay? So let me just kind of give you the lay of the land here. When we get to the information gathering section, what we're going to be looking at first are the visuals, all right? And then the visuals, after we assess the visuals, we'll ask ourselves a question, and I'll tell you what that is here in just a minute. And then based upon the response on that question, we'll either proceed on to look and assess our bedside, or we'll stop picking items in the information gathering section and move directly to management, okay? And so we'll go through this whole process, but these are the 4 elements that we're going to be using, and this is the sequence in which we will choose them. We'll choose visuals first, then bedsides, then basic labs, then special tests, okay? And at any point that we assess the patient, after looking at the things that we revealed, the new things that we revealed, we're going to ask ourselves, hey, what's going on with the patient? You know, is this an emergency or not, okay? So let's start up here at the top with the visuals. What do we mean by visuals? This is a abbreviated box that tells you some of the things we're talking about when we say visual. So this would mean that we would be selecting things like looking at chest movement, looking at sensorium, color, appearance, respiratory rate, and pattern. Again, this is not all of the possible things that they could give us. This is just to give you a general idea that it's anything that we can see with our eyes, right? Anything we can see with our eyes, that's what's considered to be a visual, all right? Now, so what we're going to do is we're going to go to the top of the page on information gathering, and we're going to start working our way down and picking all those things that are the visuals, right? When we've gotten all the visuals picked, we're going to come back and we're going to ask ourselves the question, after looking at all the stuff that it tells us about the patient, we're going to ask ourselves a very important question. And here's the question. Is this an emergency? And if we have an emergency, okay, after looking at all these things we've revealed, then we're going to stop picking anything else in the list, and we're going to leave the list and go manage our patient, take care of our patient. All right? And we'll demonstrate this on the problem 1 here in just a little bit. All right, I'll show you how this works. But so after we've done that, if there is no emergency, then we're going to go down and we're going to select all the things that fall into this category, which are the bedside items. All right? And these are my bedside items. Again, I'll let you know when I get the whole slide completed so that you can take one picture if you want to. And again, if you want to write this stuff down as we go through it, I mean, that's perfectly fine in your study guide. So here's the bedside things. These are, again, this is not a complete list. This is just a abbreviated list so you kind of know the things we're talking about. Chart results, palpation, auscultation, SpO2, ECG, monitor. This would be a bedside monitor. So those are all things that could be done at the bedside. Anything that can be done at the bedside, you would select at this point in time. Once we select all of these things, again, we go back up to the top of the list and start looking for all the bedsides and work our way all the way down the list. After we've gotten all the way down the list, we evaluate the new information that's been shared, and we're going to ask ourselves this question. It's the same one we asked before. Is this an emergency? If it is an emergency, then we're going to stop picking from the list and go to the next section and manage our patient. All right. If it is no emergency after picking these things, then what we will do is we'll go down to the next category of items to pick, and those are our basic labs. All right. So let me tell you what our basic labs are. There's 5 of them. And these are the 5, and we're only going to pick these 5, not any other lab. Okay, just these 5 basic labs. We will pick a blood gas, we'll pick a CBC, an electrolyte, a chest x-ray, and an ECG. Now, they may not have all of these in there for us to pick, but all the ones that they give us that fall into this category, we're going to select them. All right? Now, there's another thing that you need to be aware of, and that is there are some rules for picking these basic labs. And that's where I want you to drop down below the box in that open space, below the box on your study guide, and I want you to write these basic rules. Okay? Here's the basic rules. I don't have room to put them on the slide there, so I'm just going to verbalize these to you. So here's rule number 1, rules for basic lab. Rule number 1, if you have time for one, you have time for all. So that's why if I get a blood gas on this guy, if they give me the opportunity to pick a CBC, electrolyte, chest x-ray, and ECG, I'm picking all of them, right? No matter what, I'm going to pick all of them. Here's rule number 2, and I'll explain this here in just a second. After the first information gathering, repeat only what you need. Repeat only what you need. After the first information gathering, repeat only what you need. And then in parentheses, write this statement. Repeat abnormals to see if patient improved. Repeat abnormals to see if patient improved. All right, so those are the 2 rules. Rule number 1, you have time for one of these labs, 5 basic labs, you got time for all of them. So anyone that they offer you, pick it. All right, just those 5 though, don't go outside of those 5. After after the first information gathering, you only repeat what you need. So in other words, if say the first information gathering, you got a blood gas here and the blood gas was fine. And then you go and do something for the patient. And then the next time for information gathering, they ask you if you want another blood gas. Well, if you haven't changed the FiO2 or the patient's oxygenation status hasn't changed, you probably don't need to get another blood gas. You see what I'm saying? So keep that in mind. You only repeat it if you need to. Only repeat it if you need to. All right? Now, after we look at all of these labs that they give us, we're going to ask ourselves a question. Is this an emergency? And if it's an emergency, we're going to stop picking any more from the list there in information gathering, and we're going to go to the next section, move on to the next section, and manage the patient. However, if it is not an emergency, then we're going to go down and we're going to pick from this next category, which are the special tests. All right? So the special tests, these are the special tests. The special tests, first off, they have like 3 different characteristics. They are invasive, they are expensive, and they are time consuming. And so here's an example of them. The VQ scan, the MRI, the CT, the echo, the sweat chloride, all right? So this is the only time we're going to pick special tests is when we get to this point. Now, we're not just going to pick a special test because it's a special test. In other words, we're not just going to, because we see VQ scan in the list, we're not going to pick VQ scan because it's a special test. We're going to pick VQ scan if we suspect that the patient has a pulmonary embolus. All right? That's the only time we would select a VQ scan. And if they gave us the opportunity to select a CT and a VQ, we would select the CT first because that's a better indicator of the pulmonary embolus. Okay? So that's how we're going to do that. So it has to be something that we're related, that's related to our what do you call it? The problem that we're having with the patient. That's what it's got to be related to, is the problem that we're having with the patient. All right. Now, at that point, you don't have any choices to choose anything else. Anything else that's in that list, just leave it alone and leave and go and manage the patients. Okay. Oh, let me back up. So that's everything that's supposed to be on the slide. So if you want to take a picture of that, or if you want to do a screenshot, I mean, by all means, go ahead and do that. And if you've wrote it in your book, that's fine. Because you can use this on any of the simulations, for the rest of for tomorrow that we'll be working on. All right. And what this is going to do is this is really going to drive your information gathering score much higher than it typically is. Okay. Now, again, it's not perfect. It's not foolproof, but again, you'll get 90 to 95% of the items in the information gathering correct as far as picking them. Now, the big thing is you got to make sure you understand it's not just good enough just to pick the item to get points. You got to be able to know what to do with the information so that you can make a decision. That's where the decision making comes in, is evaluating your information gathering stuff. All right. So let's turn over to page 10. Let's talk a little bit about decision making here. Top of page 10 there, letter D, the purpose again is to respond to whatever the information you've got from information gathering. The content, number 2, can come from general patient care, initiating or managing mechanical ventilation, discharge planning, home care, emergency care. Those are all potential things that we could be focused on. Number 3, instructions. If they tell us to choose only one unless we make another selection, then choose only one. Now, what oftentimes they do on this test is they'll say, choose only one unless told to make another selection. And the very first one you pick is the right answer, and they say make another selection. And you just think you got it wrong, but you actually got it right. And so for me, when I see on this test, make another selection, I don't automatically think I got it wrong. What I automatically think is there's more points out there. I'm going to get more points because I know I'm picking the right answer. Okay, because I'm doing it the way Kettering told me to do it. All right. Number 4, there's an example there. After completing your assessment of the patient, you report your findings to the ED physician who asks for your recommendations. You should recommend choose only one unless directed to make another selection. And here again, here's on page 11, they give you some options here. And again, since we've got this is the MI patient that came into the rural community hospital, right? So with an MI patient, and you're suspecting MI, and you've got an ECG that tells you that and points you towards that, and the fact you've got compromised circulation, what would be your first thing you'd want to do as a respiratory therapist? Yeah, that's what I'd want to do. I'd want to administer oxygen at 10 liters a minute via non-rebreather mask. All right. And if you did that, that would be the best answer. Okay. So what you're going to need to know is before you can pick an answer, you've got to analyze the information they're giving you about the patient, summarize what the problems are, and prioritize what needs to be done first. And we kind of call this a process, know before you go. All right, know before you go. Top of page 12. We're going to kind of skip down through that because that just kind of goes through that stuff of selection and the responses that they give you. Get over to page 13. This has to do with scoring. This is important because, a lot of people kind of get wrapped up in the scoring because I know you've been in school and that's kind of where your mind is and all that kind of stuff. But as you can see here, the way they assign points is going to be based upon the relevance, the risk, the time, and the cost on page 13. If something is of central importance for safe patient care, they're going to give it a 3, a +3. If it strongly facilitates safe care, they'll give it a +2. And if it mildly facilitates safe care, they'll give it a +1. If it is mildly detrimental to the patient, they'll give it a -1. If it's seriously detrimental to the patient, they'll give it a -2. And if they are If it's gravely harmful to the patient, they'll give it a -3. And they don't really use the 0 too much anymore. Used to be that was if it was neither neutral or beneficial, they would give it a 0 point. All right, so that's kind of how they decide what the points are going to be. Now, we are not going to get into a debate about points, and I'll tell you why. Because first off, on your actual exam, your clinical simulation exam, you will not get a feedback on how many points were for each particular item. They won't tell you that. So you have no way of knowing. You just have to trust the process and the system that it's, has been set up fairly. And basically what the process is, they have a group of therapists and physicians that come together on these simulations and review them and reach a state of consensus that this is how many points that this answer should have, whether it's positive or negative, and how many points it should get. All right. We at Kettering, we do the same thing. We have a group of people that come together and they make a decision about what should be the points for each of the items. And then if they can't decide on what the point should be for the item, we've got this person that's called a boss, Scott McNeely. He decides for us. Okay. And so if you ask me the question, well, why is this 1 point versus 2 points or 3 points or whatever, what my response to you is going to be is that's the way Scott said it should be. So we're not going to get caught up in the points. What we're going to do is we're going to work through this. And I think what we've done is tried to, or attempted to do, is to design our simulations to be very, very, very similar to the MBRC format and the MBRC difficulty level, and so that it represents the exam accurately. But by no way are our simulations the ones that you're going to have to pass on the real exam. They have different set of people that write theirs. Okay, but the point being is that the steps and the content is definitely going to be the same, because they give us a test matrix for the clinical simulation also, and that's basically what we use for designing our clinical simulations. All right. So what we've done is our best effort to give you the best representation of this clinical simulation process in our series of simulations that we have you work on. Okay. So what we're going to do now is we're going to go over the clinical simulation, problem 1. And as we go over it, I'm going to show you how this process works, the circle algorithm, and you'll see how this can be helpful to you. All right. So let me kind of get out of this and get back into my other. I got to put that up before we got started. Okay. So what we've got here on page 3, back in your practice problem book, we're going to go through the first simulation together, and I'll show you how you should have walked through this one. Okay. And let me preface this by saying, if you didn't do very well on this simulation, do not beat yourself up. All right. This is all practice. What we want you to do in this process is to learn from it. So if you made a mistake, learn why it was a mistake and what you can do next time to improve on it. Okay. So this is not Kettering's attempt to try to humiliate you and make you feel bad. All right. This is Kettering's attempt to show you realistically what types of simulations you may be dealing with and how you should approach this testing process and using the strategies that we've given you. Okay, as we've talked to you about them. All right. So let's look at the first part of the scenario here. it says that you are a staff therapist assigned to the emergency department of a 420-bed medical center. Shortly after arriving for the 7 a.m. to 7 p.m. shift, you're called to the ED to assist in the care of a 37-year-old man rescued from a burning barn on his horse ranch. Now, automatically, when I see that word burning, I'm thinking carbon monoxide poison. Okay, I mean, that's just me. All right. Let's continue on. He is 5'9" and he weighs 170 pounds. So he's definitely not overweight. So I could potentially use this weight that they give him here, his actual weight, if I have to use it for calculating tidal volume. But I'm not going to do tidal volume unless, I need to. All right. I'm not going to do unnecessary calculation. When you observe the patient in trauma 4, your rapid assessment reveals that the patient is tachypnic, tachycardic, and appears to be in profound respiratory distress. Now, can you think of another word for profound? Yeah, marked, right? What does marked mean? Severe. What does severe mean? Emergency. So I've got an emergency here. I've got an emergency respiratory distress with audible wheezes, all right? So this is not good. He's currently receiving oxygen by a simple mask at 6 liters a minute. That's not good either, okay? And they want to know what we should do next. So I'm already looking down here under section A. It says go to section A, and it says your initial action is to what? And it says choose only one unless you're directed to make another selection. Emergency. How much oxygen am I supposed to give somebody if they are in an emergency situation? We talked about this yesterday. That's right, 100%. Okay? So 100% oxygen is supposed to be given in an emergency situation. And this is definitely an emergency situation because it says profound respiratory distress. So I need to look down through here and find the give 100% oxygen. Well, they don't say 100%, but they do say oxygen by a non-rebreather mask at 15 liters a minute. So that's the best answer they give me. So that's what I would have chosen. All right. It says done, go to section D. So let me scroll down over here to section D. Notice we're not going from section A to section B to section C. We skipped over to D. So obviously this is a information gathering section. It says the emergency room physician asks you to perform an initial assessment on the patient. Which of the following would you include in your assessment at this time? And it says select as many as you consider indicated in this section. So what I'm going to do is I'm going to look at that circle algorithm, right? The first group of things that I'm going to select out of this list is going to be my visuals, right? So I'm looking down through here, looking for my visuals. Do I see any visuals on this first page? I don't see any visuals on this first page. All right. So it says go to the top of the next page. All right. So we go to the top of the next page, continuing to look for my visuals. So I come down here, looks like my first visual is right here, sensorium. All right. And so I'm going to pick that one, and it says he's conscious, alert, and oriented. Okay, that's good. I see the 2 double stars, so I know I've got all the information revealed. The next visual I'm going to pick is the respiratory pattern, because that is a visual, all right? And he says he's breathing 45 times a minute, yikes. Intercostal retractions, yikes. Use of accessory muscles, marked. High-pitched inspiratory sound. That is a airway emergency, right? This guy needs to be tubed right now. I don't need to look at anything else. I know that's what needs to happen. However, we're not going to stop picking. Remember, once we start picking in a grouping of these visuals or bedsides or basic labs, we're going to continue picking from that list until we've got everything in that list selected. All right, so I'm going to keep going, see if there's any other visuals. But already it's looking like a severe emergency right now, which we already knew that from the previous information. Chest movement, he's got bilateral movement is noted. Posture, that's something you can do visually. High Fowler's position. Heart rate. Okay, that's not a visual. Skin color. This is normal lips, eyelids appear cherry red in color. That's a classic sign of carbon monoxide poisoning, right? And then the general appearance here says he's anxious, first degree burns about his face and neck, singed nasal hairs, redness around the lips, okay? Now, that's all my visuals that they've offered me. So at this point in time, I have to stop and ask myself, do I have an emergency? And the answer is yes, I do have an emergency. And so I'm going to stop picking anything else in this, and I'm going to go on to the next section that it sends me to, which says go to section C. So I'm going to back up here to section C. All right, and it says, what recommendation would you make to the physician? Choose only one unless you're directed to make another selection. Well, what I need to do is intubate this guy. That's what I figured, what I determined before I left the last section, right? That's what I know before I go. All right, so I'm looking for the thing that says intubation, and there it is. Perform endotracheal intubation. All right. Notice that we don't want to just keep him on where he's at. Initiating hyperbaric at this point is going to be no good if we don't have an airway. Albuterol is definitely not indicated, and racemic epinephrine is not going to be helpful at this point in time. Okay, we've got to get an airway because he's got a marked or severe problem. So it says done, the patient's on 100%. That's good because he's still in an emergency situation via T-piece. And then it says go to section E. So we go over here to section E. And let's see. So it says 30 minutes later, the physician asks you to reevaluate the patient condition, which of the following would you include in your assessment at this time? All right, so once again, this is information gathering. Select as many as you consider indicated in this section. And because it's information gathering, I'm going to use my circle algorithm, and I'm going to start off by selecting the things that are my visuals. All right, and I'm going to select visuals first. All right, so as I go down the list here on first page, looking for visuals, don't see any visuals yet. It says go on to the next top of the next page. Keep going. And there's my first one right there, sensorium. So I picked that one. It says conscious, alert, and oriented. Okay, that's good. And my next visual is actually the last one there, the breathing pattern. It says he's got bilateral chest expansion with no retractions. Well, that's good because now he's not having that marked respiratory distress. But those are the only two visuals that they give me. So after knowing that information, I have to ask myself the question, do I have an emergency? Well, based on these two things, no, I do not have an emergency. So what does that mean? That means I go back up to the top of the list and I start picking my bedside assessment. All right. So go back to the top of the list. I start working my way down looking for bedside. Here's my first bedside, the diagnostic chest percussion. And it says resonant bilaterally. Oh man, that's terrible, isn't it? No, remember, resonant means normal. Again, if you don't know that word, make sure you know it before you start these tests, because that's what they're going to call a normal chest percussion note. All right. All right, so let's continue on down. See if there's any other bedsides. Looks like we got one right here, chest auscultation. We got bilateral vesicular breath sounds. Oh, that's terrible too, right? No, vesicular breath sounds are considered normal with a few scattered inspiratory crackles. Okay, that's not too bad. Keep going down, find my next bedside. Here are my vital signs. Temperature is about 99.5, so it's up a little bit. Pulse is 110, that's up a little bit. Respirations are up also, and then the blood pressure is up a little bit. Okay, which again, I'm suspecting carbon monoxide poisoning, right? So I come down to the next one here, which is the capillary refill. The color returns within 2 seconds, so that's less than 3 seconds. So that's a good sign. That means he's got good circulation right now. That's good. And then letter B, letter number 10 here, tracheal position. That is midline, and that's where we want it to be. So that's good on that. So let's see if there's any other bedsides on the next page. All right, we got a bedside here. Here's something that would be in the chart. That's past medical history. It doesn't really tell us a whole lot. Fractured femur 4 years ago, appendectomy, no known allergies. So that really doesn't tell us a whole lot. Going on down, we're looking for more bedside. Here's my next bedside, social history, no smoking, no drug abuse, drinks wine occasionally. That's nothing really significant for this situation. So that's pretty much all the bedsides, all right? So what I do now is I ask myself a question. What's the question? That's right, is this an emergency? And based upon what I've heard so far on my bedside information, this does not sound like an emergency right now. Okay, now before it was, but it's not right now. So do I have time to do my 5 basic labs? Well, sure I do. So I'm going to go back up to the top of the list, start working my way down. Where's my, whoa. Got away from me here. Let's see here, get back to section E. Here we go. All right, sorry about that. All right, so the CBC is my first basic lab here, and looks like my RBCs are good. They should be around, 4.5 there, 5. Hemoglobin looks pretty good. It's about 15. Hematocrit's good, 45. White counts, that's fine. So there's nothing unusual about the white count. Next lab is my blood gas. And again, I'm going to interpret my blood gas the way we've always been doing it. I start by looking at my CO2. We know that he's on 100%, right? So his CO2 is 30, so he's hyperventilating, and his PO2 is 400. Now, most of you would look at that 400 and say, man, that's terrible, but put it in the context of the patient we're taking care of. He is a potential carbon monoxide poisoning victim, and we're giving him 100% oxygen, and we want to give him the highest FiO2 we possibly can to drive that carbon monoxide off of the hemoglobin, okay? And so the fact that he's probably tissue is a little bit hypoxic because you can't get that hemoglobin can't carry the oxygen in tissue. That's probably why he's breathing kind of fast here or hyperventilating. So in relation to this guy's condition, being a carbon monoxide poisoning suspect, this is actually a pretty decent blood gas, all right? So where is the next lab? Basic lab, okay? All right, some of you may have said hemoximetry. Well, that's not basic. That's going to be a special. Let's go into the basic lab. Any other basic labs on there? Doesn't look like I've got any other basic labs. Okay, so based upon the basic labs, I only had 2 basic labs. Those 2 things, do I have an emergency? And the answer to that is no. All right, so if I don't have an emergency, do I have time for special tests? And the answer to that is yes. Again, what is this guy's problem? His problem is carbon monoxide poisoning. Is there any specialized test that I want to do to see how bad his carbon monoxide poisoning is? And the answer to that is yes, hemoximetry. So is there hemoximetry offered? Well, yes, it is on the previous page. All right. So we get that one, and it shows that the carboxyhemoglobin is at 30%. Ooh, it's greater than John's favorite number, 20. So this is not good. So what do we do to prescribe and take care of this type of patient? Well, we put him on 100%. Well, he's on that, and give him hyperbaric if they offer it to us. Okay. So what do we know before we go here? We've got a patient who has carbon monoxide poisoning, needs to be continued on the oxygen therapy at 100% until that carboxyhemoglobin gets below 20. All right, that's when we know he can come off the 100% oxygen or hyperbaric. Okay, so it tells us here to whenever we finish selecting everything, it tells us to go back to section B. All right, here we are. It says, based on your findings, which of the following would you now recommend? So what I said earlier, I would want to give hyperbaric oxygen therapy, but as you look down through the answers here, they don't offer that to you, okay? And the only thing that's really, since he's not really in distress at this moment, continue on the 100% T-tube is what you want to do. So maintaining the therapy would be the best thing. Definitely don't want to reduce the FiO2. Mechanical ventilation is not indicated because he is ventilating. His CO2 is 30. And the racemic epinephrine is not really going to help in this case because he doesn't have the stridor at this point because he's got an airway in place. And then administering the steroids, again, is not going to help with the carbon monoxide poisoning. All right, so that's why we would not pick that. Okay? And of course, when we pick the maintain the current therapy, it ends the problem. All right, so I'm going to pause here and see if Tom has any questions or areas that we need to go back over for anybody at this point.
No, not at this time. We had one problem with one page, which I took care of, but no
Okay.
questions about what you've gone over.
Okay, all right, well, very good. So I've kind of hit the mark of where I was hoping to get to today as far as the content. So what I want to do is I want to give you guys a homework assignment. And the homework assignment, again, is the same one I've given you the last couple of days, is to chill out for the evening, if you can at all possibly do that. All right. When we come back tomorrow, what we're going to do, make sure you've got your sim book and your practice, your lecture notes and your practice problem book with you and your pen. Make sure you got that with you when you sit down. We'll start at, again, at 11 Eastern Daylight Savings Time tomorrow. And we will work through, we've got about seven sims that we do in this section here. We've done one today, so we've got 6 more to go. So we'll do 3 more, and then we're going to do a series of 3 all together. Kind of how we'll work that. All right. So what I would like to do at this point in time is offer an opportunity for anyone to ask any questions. I guess we can go ahead. If you don't have any questions, feel free to go ahead and log off, and we'll get with you tomorrow. Those of you who have questions, what I will do here is make the attempt to unmic, unmute you so that you have control of the microphones and you can ask your questions through the mic, or if you want to send them by chat through to Tom, you can do it either way. Also, if you're reluctant to use the format of talking in front of everybody to ask your question, and you'd like to contact me later, feel free to do so. Again, my phone number is 843-621-7014. And you can either text me your question or just give me a call, and I'll be happy to talk with you or answer any questions about anything we've gone over today or the previous day. So how are we doing, Tom? We got any questions at this point that I need to?
Yep. Let's see. One person wanted you to go back to the study guide. Few missed things on highlighting, so maybe we'll see if there's anybody who has questions about simulations first, and then I can give you a question.
Sure, that'll be fine.
Yep.
Anybody about anything on the simulation stuff that we did today? Again, you should all be unmuted, and if you just unmute yourself, you should be able to ask your question over the webinar platform. Wow, either they're totally bamboozled
I like mesmerized instead of
or
bamboo.
well, maybe that's it. Maybe they just mesmerized. Oh,
Let's see. Is heart rate part of visuals or bedside? Ah, that's a good question.
right.
In some of our simulation problems, it's listed separately. I will tell you that on the rest of ours in the NBRC, heart rate is part of vital signs, and I do vital signs as part of bedside.
That's right.
Okay. Yeah, we can do that tomorrow. Hemodynamics. Okay. Section A, why did we start on 15 liters instead of 100%?
So go ahead.
A4, option A4 in this problem.
Yes. Yep. Basically, it's you have it's a non-rebreather mask, and that is a minimum flow rate for the non-rebreather mask is at about 15 liters a minute. Remember the non-rebreather that we talked about yesterday, the FiO2 that it can deliver is 100%. It's capable of doing that if the flow going into it is set properly. So again, the liter flow is important to keep the bag functioning. The non-rebreather is the system by which helps elevate the or increase the FiO2 for you. So out of all of those choices, that's the only one that can give you 100% or close to 100%. And that's what you need for CO poisoning is 100%.
Okay. Question about the Babinski reflex. Is that only for babies?
Oh man, how many times have we talked about that?
That's how many times you could pick it.
That's how many times you pick it. That's right. So Curious George caught somebody, huh?
Yeah.
I think that may be in the appendix from one of the.
It is. Yeah, it's
things,
in the lecture notes in the
yeah,
definition of tests and terms or something, but you
Yeah.
don't pick
yeah. It's not
it.
one that you
My
pick.
experience has been in general, the reflexes are always distractors.
Right. Yep, I agree with you.
And I think that's about it. A couple people wanted to go back to some things in the study guide.
Okay.
And then the other one, somebody asked if you could go over the other study products that we offer.
Yeah, we're going to do that tomorrow.
Okay.
We will do that tomorrow. I'll actually, kind of show you some screenshots of stuff that's on the website and everything so that they can kind of see what we offer and everything.
Okay. Sounds good.
So where do we want to go in the study guide?
Let's see. Two things. One is some miscellaneous pages that they want to know what to highlight.
Okay.
And then one person asked if you could go over the heart picture again regarding hemodynamics.
Okay.
I don't know what your pleasure is.
Well, let's see. Let me get that
You
set
need
of
your study
slides
guide.
up.
You probably already put it away in your bag.
Oh no, I got it right here, man. I'm ready. Let's see. Let me go find hemodynamic.
Probably A60
Yeah.
is the one I'm thinking. I don't know if you want to try and bring up a slide. Yep.
Come on. It always takes a little time to load.
Now you got all those images in there.
Yeah. There it is. Okay, so there's the slide. If you wanted, if you didn't get a picture of it or a screenshot or whatever, you can certainly do that. I'll make it more pretty for you, less distracting. Whoops, got it. Okay, so basically here again, this hemodynamic slide is showing you the circulation through the body, all right? And what we did was we went through and identified the blood pressures at each of these locations, like in the aorta, this is the blood pressure, systolic, diastolic, and the mean blood pressure, mean arterial blood pressure, okay? And then we did the same thing over here in the venous system, the central venous pressures, what the normal values for venous pressures are, which is in this area here before it goes to the right atrium. And then after it leaves the right heart, the blood flow goes to the pulmonary artery. And so here are the pulmonary artery blood pressures. Okay, 25/8, 14. And from there, it goes through the lungs to the pulmonary veins, which basically that is the channels that give us the ability to measure the pulmonary capillary wedge pressure. And the pulmonary capillary wedge pressure is 4 to 12. All right. So first piece of this is that you've got to know these blood pressures, because otherwise you're not going to know if there's a problem with them. All right. If you don't know what the blood pressure value is supposed to be, you're not going to know whether it's up or down or bad or good. So you got to know that. That's the first thing you got to learn from this illustration. The next thing you got to identify is what happens if I've got a CVP problem with my CVP blood pressure. Well, if you've got a CVP problem with your blood pressure, then that means you've got a right heart problem. That's where you're at. You're on the right side of the heart, okay? And then if you have a problem in your pulmonary arteries, then the problem that you have there is a lung problem, all right? And if you have a problem in your pulmonary capillary wedge pressure, which is going to be over here before it goes into the left atrium, then that means you've got a left heart problem. So this slide, you've got to know the blood pressures, you've got to know what a problem with that particular blood pressure, what problem is associated with it. Is it right heart, is it lung, or is it left heart? Okay. Now, in addition to this, this other piece here tells you where all the double circles are. Whoops, where all the double circles are. That's where your problem is. So here it's showing you got a CVP problem. That means you've got a right heart problem. Well, what are examples of the right heart? Here's your list of all your examples right there. Okay. Here you got a problem with the pulmonary artery pressure because it's double arrowed here. It means it's up. And what are some potential lung problems that you could have? And we've got those listed for you there. So these are all the ones that you may be offered on the test. All right. Same thing here. You've got the pulmonary capillary wedge pressure problem. And because the double arrows there, that indicates a left heart problem. And these are examples of left heart problems. All right. So this box here kind of ties in with the circle diagram for the hemodynamics. All right. And so they're not telling you anything different. They're just kind of, this box is, or this illustration here is kind of filling in more detail about what is a lung problem, what is a right heart problem, what is a left heart problem. Okay. Hopefully that helps.
Okay. The next question was going over a few pages from the study guide, pointing out what they should highlight.
Okay.
Let's see, alphabetical order. E is in Edward 32.
Okay. E32. All right. So you want to highlight on page 30, E32, highlight letter B, numbers 1, 2, 3, letter C, number 3, letter A, B, number 4, drop down to letter E, number 1, letter F, 1 and 2.
Okay, next page is F as in Frank, page 5.
All right, so page F and Frank, number 5, letter C, number 1, number 2, number 3. Oh, excuse me, let me back up a minute. Number 2, letter A. Number 3, letters A and B. Number 4, letters A, B, and C. Number 5, letter A, and under letter A, numbers 1 and 2.
Okay. Next one is F as in Frank, 21.
Yay.
Oh boy.
Yeah. Number under letter top of the page, metabolic studies, letter A, highlight number 4. And then really nothing.
Yeah,
At the
that's all
bottom
I
here.
do. Yep.
Okay.
Next one is G as in Georgia, 11.
You had to get that Georgia in there, didn't you?
I did. Go Dogs.
All right, page 11, G11. Highlight letter A under Roman numeral 6 there, pulmonary rehab. Highlight letter B, numbers 1 and 2. Letter C, letter D, 1, 2, 3, 4, 5.
Okay. And then the last one is G as in Georgia, 13. Lucky 13.
All right, so under top of the page, a letter A, letter C, number 1, and under number 1, letter A, and under letter A, number 1. Drop down to number 4 in the middle of the page, and under number 4, letter B, number 3, white distilled vinegar.
And that's it from Portia.
Okay. All right. Anything from anybody else?
No, Portia says thank you so much.
You're quite welcome.
Okay. And I don't have any other callers.
All right. Looks like we're down to about 32.
Yep. And dropping.
And dropping, yeah. All right. So last call for questions. Hearing none, I will adjourn this webinar, and I will speak with you in the morning, Mr. Tom.
Okay, sounds good.
All right. Thank you very much.
Yep. Everybody have a good day.
All right. Bye.